Hello and welcome to the fourth annual Disability Health Research Symposium. We are delighted to be able to welcome you today to what is sure to be an exciting and informative symposium providing information, research, and discussions associated with accessibility and disability health. Today's event is brought to you by the U-M Center for Disability Health with funding provided by the Ideal RRTC and the AHEAD RRTC, NIDLR-funded rehabilitation research and training centers. Accessibility accommodations are supported by the Office of Health Equity and Inclusion at Michigan Medicine. My name is Dr. Michelle Mead, and I am the director of the Center for Disability Health. You'll be seeing me throughout the day as we go on. Dr. McKee, if you also want to introduce yourself, and then we'll move on to discussion or introductions by Dr. Brown.
Absolutely. Thank you, Dr. Mead. My name is Mike McKee. I'm an associate professor at the Department of Family Medicine and co-direct with the CDHW with Dr. Mead. For those who may have low vision, I'm a middle-aged white male. I wear a cochlear implant and glasses. I have a sort of a purple sort of striped shirt. And I'm delighted to welcome everybody today. And I totally second that this is going to be a fabulous series of presenters joining us today. And for those, just want to bring to everybody's attention that we have captioning services available, as well as an interpreter who is currently spotlighted right now.
Just a word about the Center for Disability Health and Research. Once again, the Center for Disability Health and Wellness at the University of Michigan's mission is to develop and apply innovative research, clinical, and educational strategies to address inequity in healthcare access, quality, and outcomes experienced by individuals with disabilities across the lifespan. Simply speaking, we want to transform medicine to be more accessible, relevant, and engaging. This symposium and especially the topic of policy is so critical to those missions and goals. We're delighted with this symposium to be working in partnership with the Office of Health Equity and Inclusion and Dr. Brown. Today's schedule, as you can see, is packed. That we have, we'll be starting with introductory remarks by Dr. Brown in a minute. We'll then go on to a policy workshop by Dr. Baum and the wonderful faculty and staff at the Center for Healthcare Research and Transformation before breaking for lunch. Our speaker this afternoon is Dr. Robyn Powell, a noted lawyer and expert on accessibility issues. And then we have a number of research presentations. And finally, questions and answers, discussion, and closing the day at about 4 o'clock. A couple pieces of housekeeping. This event is being recorded, but if there are breakout sessions, depending at the end of the day, those will not be recorded. We will be posting everything at the CDHW website in the upcoming weeks. All attendees start muted, and then we'll move on from there. Presenters, with the exception of the keynote speakers, will introduce themselves, and it's important for all presenters to speak up, speak clearly and at a moderate pace so that the captioner can caption appropriately. Please use the raise hand functions for questions or comments. And when it's time to move to the next presentation, use the chat box feature. Finally, please remember to fill out the evaluation survey that you'll be sent after the symposium. And with that, we'll go on to Dr. Brown.
Let me go ahead and do the introduction. So I have the honor of welcoming Dr. David Brown to be able to give an overview, and we appreciate the ongoing collaboration and support with OHE. So Dr. David Brown is an Associate Vice President, Associate Dean for Health Equity and Inclusion, and Professor of Pediatric Otolaryngology at Michigan Medicine. Dr. Brown leads the Office for Health Equity and Inclusion at Michigan Medicine, which oversees the University of Michigan Diversity, Equity, and Inclusion Strategic Plan. He is an executive sponsor of the Anti-Racism Oversight Committee and the Health Equity Roadmap. He is a member of the Association of American Medical Colleges, known as the WAMC, but he also is a member of the group of on diversity and inclusion and was the central region representative for the WAMC GDI from 2017 to 2019. Dr. Brown graduated from Brown University and Harvard Medical School. He completed his residency in otolaryngology, head and neck surgery here at the University of Michigan, and completed a fellowship in pediatric otolaryngology at the Children's Hospital at Boston. He was honored with the Harvard Medical School 2020 Distinguished Alumni Service Award for co-creating an alumni mentorship program for medical students underrepresented in medicine. So we are delighted to have you here, Dr. Brown.
Thank you very much, Dr. McKee, for that kind introduction. I'm delighted to be here as well, and welcome everyone to the 4th Annual University of Michigan Center for Disability Health Research Symposium. I'm so excited you're all here. For those with vision issues, I'm a middle-aged mixed race man with black curly hair with some gray highlights. I didn't put them in, they came naturally. And I'm wearing a gray jacket and a light blue shirt. Thank you, Dr. Michelle Mead and Dr. Mike McGee, and all of the organizers of this really important event. I'm excited for what people are going to share and learn. The Office for Health Equity and Inclusion is proud to support today's event with accessibility accommodations. I feel this is important so that everyone can participate and be a part of the experience. The Office for Health Equity and Inclusion's vision is to create a world where every person feels valued and can thrive. That's every person who comes here for care or to learn, even to a symposium or visit, anyone who walks through our doors and through the Academic Medical Center or walks through our Zoom doors. Our mission is to honor the well-being, individuality, and dignity of all who work, learn, and heal at Michigan Medicine, and to champion diversity and inclusion for our patients, our community, and society, and to diversify the next generation of physicians, nurses, health professionals, and scientists. Our vision and mission also applies to individuals with disabilities, and we're really proud to have an ongoing partnership with the Center for Disability here at Michigan Medicine. We actually are also proud of having outstanding individuals with disabilities in our pipeline programs, in the medical school, our residency program, and on our faculty. During our 3rd annual Youth Summit at the Big House, where we host over 400 diverse 4th to 12th graders in clinical simulations at the football stadium. We're happy to work with Drs. Mead and McGee to bring students with disabilities so that they could realize that healthcare is within their reach as well. The Office for Health Equity and Inclusion is also proud to sponsor resource groups, including the Disability and Chronic Health Conditions Forum. The resource groups are a mechanism for faculty, staff, and learners to provide feedback to the Michigan Medicine leadership on how to foster inclusion and collaboration. The membership-led resource groups have the opportunity to catalyze efforts to drive innovation and make workplace culture more inclusive, engaged, productive, and aligned to support all of our strategic goals. At Michigan Medicine, we're constructing our health equity roadmap right now. We're using 6 levers of transformation as defined by the American Hospital Association. The 6 levers for our health equity roadmap include 1, culturally appropriate patient care, 2, equitable and inclusive organizational policies, 3, community collaboration for solutions. 4, diverse representation and leadership and governance. 5, collection and usage of data to drive action. And 6, systemic and shared accountability. We include individuals and policies that impact individuals with disabilities and wellness and the Health Equity Roadmap. And our goal is to have a user-friendly and searchable database that catalogs all our diversity, equity, and inclusion and health equity activities while simplifying awareness and opportunities to connect with others interested in similar work. This is the first time that we've intentionally started a plan to decrease health disparities while increasing diversity and cultural competence. Also, having a focus on individuals with disabilities is crucial for our faculty, staff, and learners and their success. I hope that today's symposium informs us of opportunities to help all individuals at Michigan Medicine and the world feel valued and thrive. Thank you all for sharing, learning, and advancing our knowledge, our awareness, for our awareness of policies and actions that we must take to advance the experience for all. Thank you, and go Blue.
Thank you so much, Dr. Brown. It's really exciting that you're here and that once again, this partnership emphasizes how individuals with disabilities are included in the initiatives for diversity, equity, and inclusion. But we know that these initiatives and their translation into real outcomes don't just happen, that they are made possible by people's vision and by policy. In a few minutes, we'll be introducing Dr. Nancy Baum, but we want to also emphasize that policy is about all of us. Policy is about the translation of what we do as researchers to inform what needs to be done or how it should be done in practice. It highlights the research highlights the issues that are come up, hopefully includes the diverse voices of individuals with disabilities, of individuals from traditionally underserved and underrepresented populations. And it looks for solutions that are naturally there or providing controlled interventions and programs that allow us to understand and move forward. From these, we move to policy. What is going to work? What steps need to be taken and how does it need to be operationalized to apply to everyone? How can it just be more than this happens for one person, or this is what we think should happen, so we're going to do it, but it's not going to be translated across the board. With the Center for Disability Health and Wellness, one of our key actions in transforming healthcare is to help provide best practices, is to help provide tip sheets, to provide education to many stakeholders and to talk with them about which are the pieces that need to be translated, that need to be operationalized so that they can result in systemic changes at both organizational and national levels. Michael, did you just want to say what? I know that you're currently doing a policy fellowship. Can you say a word about the importance of policy, particularly for DEIA?
Thank you, Dr. Mead. Absolutely. I think the key thing right now is just being intentional to include us. And these are individuals with different types of disabilities, and also recognizing the importance of looking at intersectionality factors because they will compound a lot of the inequities and health disparities that we see. Also, we are coming together here at University of Michigan and Michigan Medicine. Obviously, in Michigan Medicine, the value, we're trying to make sure that we are intentional following the principles around BASE, which is belonging, inclusion, access, safety, inequality, and experience. And this has to be inclusive for people with disabilities. We are right now, over the last several decades, have demonstrated a lot of inequities. And what we're trying to do here with our partnerships, our interdisciplinary work, our various grants and education, to be able to advance and address a lot of these inequities through creative programs, quality improvement projects, medical education, disability health, and cultural awareness. And so this cannot happen without the partnership that we are building. And we also want to just put out a challenge and a charge for all of us to make sure that we partner closely together, think about us, as well as we engage in your various initiatives and make sure that we're represented.
As we wait for Dr. Baum to come in the room, I'm just going to share for a moment about the Center for Disability Health and Wellness and our new grant on health equity and inclusion, or health equity in health and functioning. Once again, the U of M's Center for Disability Health and Wellness its mission is to develop and apply our innovative strategies. Key activities and initiatives include research to identify and address healthcare disparities for individuals with disabilities, to enhance awareness of disability-related disparities and healthcare disparities, to create opportunities for interdisciplinary collaboration and networking, to conduct regular membership meetings and events such as this one, to build collaboration with community organizations, to conduct training and capacity building. As Dr. Brown mentioned, we were very excited to be part of the Youth Summit this past May and hope to build on that in the months and years ahead, ensuring that all individuals with disabilities, from kindergartners up to college students and beyond, know of their importance and the potentials and the opportunities within healthcare. We're also providing resources for both researchers and clinicians and conducting advocacy and support. We are currently funded by 4 specific grants, including the IDEAL RRTC, which is focused on promoting healthy aging for individuals with long-term physical disabilities. Our Michigan Spinal Cord Injury Model Systems, which is a partnership with the Mary Free Bed Rehabilitation Hospital in Grand Rapids to improve the lives of individuals living with spinal cord injury throughout the state and nation. With partnering with Brandeis University for a rehabilitation research project on pregnancy and disability, and our Rehabilitation Research and Training Center on Equity in Health and Functioning, which we have now titled the Advancing Health Equity for Individuals with Disabilities from Diverse Communities. And once again, we are building on current a history of successful grants and programs and centers. We have developed a strategy for communication here at the University of Michigan, and I hope that you're each aware of these and using it as an opportunity to communicate and engage with us. This includes our quarterly webinar series, 2 social media pages, one on a Facebook group and then a Twitter profile. We have a quarterly newsletter that folks can receive in their email inbox basket. We host this Disability Research Symposium, and we really want to be able to feature the works and the policies that are going on. But right now, I'm very pleased to be able to expand more and to be able to, introduce Dr. Nancy Baum. As mentioned, policy is such an important part of what we do and how we make an impact. It's about the translation and going beyond a paper on a shelf to something that's going to have an impact on people's lives. Through first the Ideal RRTC and now the DC RRTC, we have been partnering with the Center for Healthcare Research and Transformation. I'll let Dr. Baum say more about her important organization, but we found this partnership so critical both for enhancing our own knowledge and helping to hopefully move the needle and increase awareness about the issues individuals with disabilities experience first during COVID and throughout, the lifespan. Dr. Baum is the Health Policy Director for CHART. She leads CHART's work in developing and managing health policy projects in healthcare reform, health status improvement, access to healthcare, local public health, and behavioral health. She has a deep expertise in the areas of mental health and substance use services, including coverage policy and provider payment in Medicaid and private insurance, workforce challenges and innovations, as well as integrated care models. Nancy earned her PhD from the Department of Health Management and Policy at the University of Michigan School of Public Health and her MHS from Johns Hopkins Bloomberg School of Public Health. She has served as a board member for the Washtenaw Community Health Organization from 2013 to 2015, and is one of the leads for the CHART's Health Policy Fellowship, which is enhancing the capacity of researchers to transform their work, but also creating a cohort of policy makers, researchers, and community organizations that can talk and understand one another and communicate to hopefully improve the health of everyone. Thank you so much, Nancy, for being here and for your workshop ahead.
Thank you, Michelle. Thanks very much for that introduction. Yeah, I'm delighted to be here. And as Michelle said, I direct our health policy work at the Center for Health and Research Transformation. We call it CHART. And but really, policy runs through all of the work that we do at CHART. I'm happy to talk a little bit more about that organization. If anybody's interested, we are a nonprofit, but we have a special affiliation with Michigan Medicine. And we really are all about trying to ensure that policies are.
Thank you.
I probably haven't had any trouble in months. And it was not until I was supposed to be a speaker at a morning symposium that I had trouble with my connection. So my apologies. I hope that's it for the day. I think I was telling you a little bit about our center and how important it is to us. And I think to all of you as well, that policy that's made is informed by evidence. That evidence that researchers are building in their work, and that I know many students are getting involved in and interested in being involved in. And one of the things you can think about is not just creating peer-reviewed journals or journal articles that are read by perhaps people directly in your field, but really not by legislators and not by most policymakers. And so you want to think about what else do with the evidence that we develop to ensure that it's used when it needs to be used to inform good policy. So that's really what we're going to talk about today. So I'm just going to jump right in. And I think that this is the most important of all the slides I'm going to share with you today. And it's because really the motivation for this is to ensure that your research has impact. That's what I think most people are here for. This is why I think a lot of researchers get involved in policy and policy issues. Michelle knows, and others, I don't know if Mark Peterson or other people are on today, but we have had a number of researchers participate in our policy fellowship. This is where we bring researchers together with policymakers from Lansing and also with leaders from nonprofit organizations to learn from one another. Researchers have a lot of substantive knowledge to teach people who are working in Lansing and making policy. And the way that policy is made, the processes are really important for researchers to understand. So that's what we do with that policy fellowship. But the whole idea is let's ensure that the research has impact. So to be effective, you need to know who you're going to work with, who you need to work with, how to share your findings. It's not as though you hand legislators or other policymakers your journal articles. They will not read them. They absolutely will not read them. And so it's really important to think about, well, then how do we communicate in a way that will get through? And when do we do it? There are timing issues, et cetera. So these are the kinds of things that researchers need to think about. So the influence really, when we're talking about defining public policy, it's really about influencing government actions on citizens. This is the way we usually think about it, but this is not limited to government action. And we'll talk about that a bit in the next couple of slides. But policies are really what we use to show intent, what our elected officials and others use to implement their policies, their priorities. And these decisions shape everything else. They shape programs. They help us achieve our social goals as well as economic goals. And health policy is just one type of public policy. And then, of course, the way we talk about it most often is as public health policy, because and by we, I mean those of us working at CHART and lots of researchers as well, who are really looking for big systems change and thinking a lot about community health. So the laws, rules, and regulations, these are the types of policies that I think we think about most often. Operational decisions really are policies about, how agencies are going to work what it is they need to do. So when CMS, this is the Centers for Medicare and Medicaid, so they run both Medicare at the federal level and then Medicaid at all 50 states. Medicaid's a partnership between states and the federal government. When they're going to, say, administer claims for doctors and hospitals, it's not spelled out in the law that created Medicare exactly how they're going to do that. And so they need to operationalize that law, and they do it through writing regulations and making these kinds of administrative decisions public through the Federal Register. You may have had an opportunity to comment on something that was being published in the Federal Register. Judicial decisions, I think we all understand those as being made at many levels of the United States, Supreme Courts of each of the states, and then our local courts as well. These are not places that most people like health services researchers necessarily have direct impact. We're really having impact more in the operational decisions and in the laws and rules. Many policies are also allocative, so or distributive or redistributed. And we like to think about that as sort of who is going to be the net beneficiary of a regulation and where will the power or the money or whatever it is you're redistributing come from. And so allocative policies work in that way. An example would be federal dollars to support the veterans healthcare system. So federal dollars contributed by all in the United States, but really goes to a system that doesn't serve everybody. It serves a specific population. So that's an allocative or redistributive type of policy. We have lots of regulatory policies, what you can and can't do. These really influence actions, behaviors, decisions. These are often economic, but they can also be social. So they can be about price setting. They can be about quality controls, like the FDA standards for drugs, things like that. but some are more social in nature, and they're really trying to achieve socially desirable outcomes. So, for example, we might be trying to reduce sexually transmitted disease through public health surveillance and through public health education. These are what we think of as regulatory policies. So a lot of these also have economic effect, but perhaps the main purpose is for social desirability. I'm going to stop there. Anybody have any questions? Any of that unclear? Nothing. Okay, let's go on. So the purpose of public policy, and let's think about it in terms of health policy, the general purpose really is to solve a problem or to lessen a problem. They are sometimes they're little detailed fixes that can affect a small number of people. Sometimes they're huge. The ADA is an example of a huge federal policy that really has had a great impact on a lot of people for decades. I think a lot of disability researchers are painfully aware of some of the things that the ADA has not solved. And so follow-on legislation to that to lessen or to remedy some of the problems. So we really think about policy as an intervention. I think that's a very straightforward way to think about policy. There are economic perspectives. So sometimes what we're trying to do is improve equity. And equity can sometimes be thought of in terms of economic aspects of a policy. It can be trying to improve on market failures or other issues that create inequities. And we also have, of course, inequities, not just in economic policies, but also in social policies. So as I said, some policies are trying to really solve social problems. And so these are broad ways to think about what policy is. And I think sometimes we just want to start there because people who don't work in policy all day long may have one idea, but I'd like you to think quite broadly about what policy is. I'm going to show you some typologies. These are just ways of organizing ideas. This is just another way to think about what policy is and why it's important. So speaking of why it's important, I think that I've been giving you some examples here. Everybody's aware to some extent policies, I think, that shape health systems. And as the slide says, it shapes money, power, resources, and how they flow through society. It really, we're trying to use policy to solve problems, not create further problems. And with the hope, of course, that this is going to improve lives and improve well-being. As you all know, different political parties have different ideas about what social changes and improvements they're looking for. And it's important when you're working in the policy space to be aware of some of those differences. And we'll talk about that a little bit more too. I think that one way we think of some policies has also to do with societal moral principles. And I think that's a little bit harder to talk about, just because I think when we live in a society, we recognize how varied that is. And I think in the policy realm, sometimes that really comes to the fore. And we're very aware of all of those differences and how policies may or may not be able to shape those in the way that individual policymakers and citizens want to do. So it's really about trying to solve problems efficiently and effectively. So I'll just give you examples. State laws really shaped the Michigan Medicaid program. And, you know, an awful lot of what's provided through Medicaid are long-term support services. And of course, the waiver that allows for home and community-based services. And other examples are, in the state of Michigan, we tell people whether or not they need to wear a motorcycle helmet. Today, they don't need to. A few years ago, they needed to. But these are examples. And so I'm wondering what kinds of examples jump to mind for you as people working in the disability space. I see Michelle has her hand raised.
Thank you, Nancy. And I think the question of what examples come up is so, my question was actually, how do you let people know that the issues are important within the disability space? The issue of being seen, being identified is so important. Often issues associated with disability, acceptability, being counted, are just not recognized. Disability is not welcome or invited into the room too often.
Right. And you're really talking about sort of deep societal priorities and perspectives. And so one of the really important things, and we'll talk about this in a few more slides, one of the really important things to do is to think about what are the policy levers? What can policy do to have an impact on the very things that you're talking about? Would love to hear what other disability researchers, students, all of the people who are attending today, what thoughts do you have about examples in the disability space? Mike, I see your hand.
Thank you for this overview. I think for a lot of disability health researchers, I think we're so struggling to connect and be able to influence policy. But with that being said, I think really working with our disability organizations, our community partners, many of them often have attorneys on their board. And so those are probably, I would consider, better avenues. So again, this concept of a teamwork, partnering, because they've already facilitated some of those connections. The other question I have regarding these policies is sometimes we have executive orders, and we've had some executive orders from President Biden, who actually has spelled out about trying to advance equity. And this is not only for people with disabilities, but race, ethnicity. Executive orders are very different from some of the laws that we're more used to, like the Americans with Disabilities Act legislation. So I was wondering if you can maybe, I don't know if you're going to cover that or not, but like strategies around that too.
Right. So I think the distinction in most people's minds between an executive order and a piece of legislation that's passed is that it isn't the folks, and we're talking at the federal level right now, but we can have an analogous conversation at the state level. What we're talking about are powers in the different branches of government. So of course, 3 branches. We have a legislative branch, and these are the people who are elected to the House and the Senate. We have a judicial branch, and we also have our executive branch. And our executive branch is where our president, or at the state level, where our governor and lieutenant governor are elected. When you are running the executive branch, you have a cabinet of individuals who report to you, who are expected to carry out your priorities. And they have departments that they run, and most departments, multiple agencies within the department. Those agencies are often responsible for writing regulations that are our guideline about how policies get implemented. There is power in the executive branch, different than the power that is in the legislative branch. So the power in the executive branch may not be to change the letter of the law, the law for Medicare, Medicaid. in 1965, the executive branch may not be able to change the words in the Social Security Act that created those programs, but what they can do and what they have power to do is more in the execution of how that law is implemented. So when we think about executive power, we think about something that's not changing the letter of a law, but is using the elasticity, if you will, or the flexibility in the way something is implemented on the ground. And so I think that's the way to think about executive action. I see once again that my internet is unstable. My apologies, honestly, it's just Murphy's Law. So I hope that answers your question. I can't give much more specificity than that because almost by nature, we can't always anticipate what an executive is going to, an area in a way that they're going to take action. And different policymakers are creative in different ways about how they do that. I think we often talk about executive orders as if they're sort of under the table or, haven't gone through proper processes. And I think often what's going on is that most of us don't understand all of the power that does exist in the executive branch to actually implement change. Anyone else?
Nothing in Q&A right now.
Okay, very good. So as we go on, do think about other examples that come to mind for you in the disability space. My examples are not all, my examples are broader, but would love to sort of bring it the discussion more into the realm of everybody here. So let's think a lot about who policymakers are. We've been talking more about sort of federal, state, and even local elected officials. And those are very important policymakers. And I think those are the ones that are the easiest to think about and talk about, but very often they are not the most powerful. A really good example of powerful policymakers who we don't often think of as policymakers are these non-elected decision makers. So a really good example in the state of Michigan would be the people or person at Blue Cross Blue Shield of Michigan who makes coverage policy. Somebody in every insurance company decides which services are going to be covered and how much they will pay for that covered service. Well, Blue Cross Blue Shield of Michigan covers more than half of the commercially insured lives in the state of Michigan. So we're talking about probably more than 5 million people. And that person is not known to most people. That person in each insurance company in the state isn't known to most people who want to have an impact. And so sometimes it takes some legwork to really understand who are the decision makers who are really impacting what I want to change. I'm trying to think of some other examples of non-elected. So leaders in professional societies. These may not be people you think of as policymakers, but if your professional society is creating clinical guidelines, and those clinical guidelines are going to be used, maybe even JCO and others who do, they go out to health systems and ensure that quality is being met, or are used to create national quality standards. Boy, the people in that subgroup of your professional society who are creating are really policymakers. Those policies really impact a really large number of people. Don Berwick, I have a quote from him on this slide. Don Berwick, Institute for Healthcare Improvement. I suspect even if you don't recognize his name, you've probably seen him. He's a very prominent person in the world of quality. And he talks about policymakers in this way. Policymaker sets the rules and provides the resources. Policies, the creative molding and context setting for the care that providers want to deliver. He's talking about this in the context largely of traditional health systems. But I think that his wording about creative molding sort of goes to your point, Mike. I think about executive power and how it's used in different ways depending on who the executive is. So I don't know if anybody is surprised to have such a broad definition of policymakers. Can you think of people in your world that you would like to influence, and do you see them as policymakers? Would love to hear from you. If not, just think about that question as we go along today.
Michelle has a hand raised.
Wow, and I hopefully there will start to get some comments here, but the idea of who can be a policymaker and that it's not just the elected officials, and thinking, as you said, that of the manager in a department, the leaders of organizations, definitely judges, and how those individuals interpret and laws and make policies through those steps. I hadn't thought about clinical practice and the development of those guidelines. Insurance company, I know, are policymakers who have, a key impact on many individuals with disabilities as they accept or reject requests for coverage support for various services or equipment.
I do have one sort of comment on perhaps a successful change that really happened by a group of leaders. Some of them are in the disability health area. So in 2017, the law was passed to expand Medicaid coverage for hearing aids. And so now what we have done is allowed hearing aid coverage for a group that struggled to get these services. Historically, this was only available for children under Medicaid, and that was expanded to allow for even adults to have that. So this was one of the few I would consider expansion of hearing aid coverage across the state and also on a federal level. So in 2017 would probably be another example of hearing health specialists, organizations trying to advocate for improved access to hearing aids. So that would be another example, I think, of a successful impact on a policy and organizations and researchers working together.
I would like to go to this typology that I think some of you may have heard of. It's a way to think about policy in a couple of different categories. Sometimes this helps. These are not hard and fast, and it's not important to remember this. It's just a way to understand policy. Sometimes we say big P policy when we're talking about state and national laws, regulations, executive orders, to Mike's point, court rulings, and we refer to big P policies as policies that have a really serious consequence for not following them or violating them. They may have a really big impact at a systems level, or they may just impact a lot of people. So you can think about policies in that way, and then you can think about small p policies. So these are going to be perhaps agency level policies, maybe recommendations from expert panels that may get implemented in various ways, or may become part of the evidence that feeds one of these big P policies. Often these are smaller in scope. Often they are less formal in a certain way, but they're really a nice opportunity sometimes to create quick changes, as I say, that could lead to larger changes. So I used to work at the Centers for Medicare and Medicaid, and we would think of ourselves most often in the big P policy space. But often we were greatly influenced by what was happening in the small p policy space. Sometimes because interested members of the public, professionals, etc., would come and share that information about here's what we're doing with this small p policy, and we think it should have this impact on big P policy. So again, these are not cut and dry, and you're going to see variation, but it's sometimes typologies help when people are starting to think about what policy really is. So some examples.
And we have a question in the chat for you, if you don't mind.
Terrific.
Taking it.
Happily.
All right. Haley asks, could you please comment on the opportunities and challenges of joint advocacy among marginalized communities? I'm thinking specifically about the recent NIH decision to acknowledge that disabled people are among those who experience health disparities. It seems like sharing the labor of advocacy and having more voices at the table could be useful, but could also result in conflicting or fragmented objectives. What do we need to keep in mind to maximize benefit to the community as we move forward under this new policy?
Yeah, thanks, Haley. That's a great question. I think one of my very last slides is sort of distinguishing between policy and advocacy. And there really are distinctions. They are partners. They are important to one another, but they are different. And so it sort of depends on whether, in essence, you're talking about evidence or you're talking about values. And often, again, those are blended. But I'll get a little bit more into that toward the end of this talk. But I think that the idea of working together with other people with common interests can be done both in the policy space and in the advocacy space. In fact, it's essential in the advocacy space. But I think that it's a distinction that is really important to think about as, we're employees of organizations, and we might be able to have a policy role in, if you're a researcher at the University of Michigan, sharing the evidence that you've created and your knowledge about what the evidence shows. You may have to take off your University of Michigan hat if you want to be working in the advocacy space as an individual with a perspective shared by a group of people that you're with. So I'll cover this a little bit further, but I really appreciate you raising that distinction. It's something that is just essential to think about. Any other questions?
Yes, there is one more in the chat. Leslie asks, this brings up the question, who has the power, the policymakers or the stakeholders? This is unclear and can be the fundamental cause of health inequities. What are your thoughts on power as it relates to policy and policy change?
Right. So I think that my first slide talked about impact. And I think one way to think about power is to think about impact. And so part of what we're talking about today is how to empower researchers and others to use the evidence that they build to have an impact on policymakers at big P policy levels or little p policy levels. So I think one way to think about power in this discussion is to think about the power of researchers and others, stakeholders, as you point out, to bring evidence, hopefully, to the table that can impact policymakers. In the advocacy space, it may be less of a priority, not always, but it may be less of a priority to bring sort of evidence generated by researchers in the way that we think of that evidence. And it may be more important to come in with a message about that sort of falls in the moral suasion category. Of course, as I said, these advocacy and policy, work hand in hand often. And so it is a little bit hard to distinguish. You've made a couple of points about health equity. I'm so glad you brought that up because this is in our lexicon today, but I think it's something that hasn't quite worked its way into the research world in the way that I think most of us would like it to. I think that we need a lot of really good data so that we can really be clear about, for example, subpopulations who may be treated inequitably in our existing healthcare system. So if you're coming at a policymaker from an advocacy perspective, you might be talking about health equity in one way. And if you're coming at a policymaker from another perspective, you might be, you may have some data to show them, to say, African American moms are dying at a much higher rate in childbirth than other moms, and here's the evidence that we want to show you. From an advocacy perspective, you may say, this is inequitable and it needs to be changed. It's inhumane. You might come in with other ways to talk about health equity to a policymaker. So I hope that starts to go to your questions. Any other questions?
None right now.
Okay, thank you. So just very quickly, you can see some examples here in the big P. I would also put things like Medicaid expansion that probably most of you are familiar with from the 2010 health reforms at the federal level. Also HIPAA regulations. You would put probably in this big P policy bucket. They have big consequences. They affect a lot of people. They've completely changed the way much of healthcare is provided. So examples here, I won't read through them all for you. And then small p, you might think about hospital policies, for example. I think many hospitals have policies for screening for domestic violence. This is a policy in the institution, but it may not be governed by a law. So that might be in a small p policy, even though, hospitals treat a lot of people and presumably a lot of people would be screened. So you could see how that might fit in either one of these. So would love to hear if anybody has ideas from the disability space, what we haven't talked about that might fit in big P or little p. Anybody want to do that?
Nancy, we have one more question.
Terrific.
As a medical librarian specializing in knowledge synthesis methodologies, I've been concerned about the influence of evidence-based methodologies on policy formation and the trend of evidence-based policy, given the weaknesses of evidence-based methods, their focus on historical consensus, their dependence on an inequitable knowledge base, and their inability to provide flexibility or responsiveness for changing context or to accommodate emerging trends and discoveries.
Yeah.
Perhaps I am misunderstanding evidence-based policymaking.
No, I think what you're doing is questioning what we should be considering as evidence. And perhaps what you would want to do is influence from your librarian perspective. You might want to influence what it is that peer-reviewed journals decide to publish. That would be a small p policy. It would be a policy that would be implemented by the editors of a journal, and you might go to them and say, here's what the kinds of articles I'm seeing are based on this kind of evidence, but I think there's other evidence here that really should be used to impact what you're publishing. And so I don't think you're off base at all. I think what you've done is illustrated a really nice opportunity in the small p policy realm to say, I could go, I'm just using, off the top of my head, this example of talking to editors of journals, peer-reviewed journals that are very important, that have a great influence on, as you say, building evidence that's then from my perspective, then hopefully used to influence policy. But if you don't agree with what evidence should be influencing policy, then you have an opportunity to intervene there. Anything else? Anybody have anything you want, examples you want to add to these boxes, big P, little p? If not, I'll go on and talk about another sort of typology. Again, just another way of thinking. Think about the right-hand column essentially as the action that goes along with each type of policy. I talked about moral suasion a little bit, but you can see, a policy that would fall into the category of sort of incentives might be a tax imposed. There are, procurement and then laws and regulations. I don't think we don't have to spend a lot of time on this. I'm paying attention. I know we're scheduled to have a break at 10:20. I even set an alarm for myself, so if you see me jump when my phone goes off, you'll know why. But trying to get through just a few more slides before we get to that break. So again, not important to memorize a typology like that, but just important to help organize ideas here. So there is a concept in policy that's referred to as the iron triangle. And this is what I was starting to get at when I was talking with Mike about executive, with all of you, but thanks to Mike's question about executive action. And the iron triangle is the way that people who teach policy, people who talk about policy more in an abstract way, think about who are the influencers. And really this triangle is really made up of people who you might not quite think of as the policymakers. So for example, in this third bullet, it's not elected members of Congress who are one of the three legs or one of the three points in the iron triangle, but it's actually the congressional staffers. And so the iron triangle is saying, where is the real action going on? And so people who are trying to influence policy think, yeah, it might be important to go in and have a conversation with my elected official. But what I really want to know is who staffs the committee that is going to consider the bill that has the language in it that is going to impact change. So congressional staffers. So earlier when I was talking about the health policy fellowship that we run at CHART that Michelle and others have been a part of, we don't invite the elected officials to take part in the fellowship. We invite their staff. And it's partly because we really feel that researchers can learn the most and build relationships with these staffers. But also the staffers can be very a little more frank in the way that they talk about processes. They can really help to educate people who are interested in having an impact in policy about what those processes are, timing of budget cycles and things that are central if what you're trying to do is impact, say, allocation of funds. So it's the staffers. It's the mid-level managers in the executive branch. So it's not the elected president or governor at the state level. It's not even necessarily the person in the cabinet who runs that department. It's closer to the person that runs the agency. So at the federal level, you might think of the Department of Health and Human Services. One agency within the department is CMS, and CMS has the responsibility both for the federal Medicare program, so 65-70 million lives there, but also the federal role of the 50 state Medicaid programs. And so the mid-level managers within the executive branch, the congressional staffers, and then to one participant's point a few minutes ago, the interest group representatives. This is potentially a very powerful coming together of these three groups to actually influence change. I'm going to give you one brief example of something that I was involved in many years ago when I worked at CMS. Back in the day, millions of people eligible for covered by Medicare really were faced with a problem that there's an awful lot of cost sharing in Medicare. And so a whole industry built up of policies that people could buy that complement Medicare, so that when you had a health event, you didn't have such an enormous amount of out-of-pocket spending. We called them at the time Medigap policies. Today they go by different names. But the industry was not very well regulated, and insurance companies could sell elderly people, for example, perhaps vulnerable elderly people, multiple policies, even when there was overlap in benefits. And so people, who didn't understand the complexity, who were very nervous about a health event and what it would cost them, we're buying all these policies. Well, this was very bad for consumers. And so the CMS put together a group of executive branch middle managers, interest group representatives. And so interest groups, including the insurance industry, including people from AARP, sort of at the time representing people who were being taken advantage of. And then, so bureaucrats from CMS and industry representatives, and then folks who were the Ways and Means Committee in the federal House has jurisdiction over Medicare. It's one of the two House committees that has jurisdiction over Medicare. And so people from that committee were there. So the folks from CMS were saying, we're going to help you think about how to standardize policies so that people don't get taken advantage of. You can only buy policies now A through J or something, and they can't overlap. There are all kinds of standards now in place. But those bureaucrats really knew the Medicare program inside and out. And so when you're talking about designing insurance, you have to really understand what the complementary nature of that insurance and the Medicare program and what benefits and cost sharing were in place. And the folks from the insurance industry were saying, this is a really big and important part of our business, and people really want what we're selling. And so we need to have a voice at the table. And the AARP representatives in this particular case were the ones who were sort of the most vocal about the harm that was being done in the current system and what they needed to see changed in this process. And then the folks at Ways and Means were thinking, how am I going to write a bill that really makes these changes to the actual Social Security statute in Medicare so that these policies cannot be abused in the industry and people can get what they want. So kind of a long-winded explanation example of how this iron triangle works.
Nancy, there's a
Yes.
question in the Q&A about
Great.
what about policy and competing access needs, like the service animal example or people with allergies?
So
Yeah, that's what's there. We need
okay.
more.
Yeah. So I'm trying to decide if by competing needs, what you're talking about is the person who needs the animal sitting next to the person who's allergic to the animal.
I think that's it, right?
Yeah. And I think that what you're talking about there, or what could potentially be what you're talking about, are small p policies that could be something like, does Delta Airlines have a policy about whether, somebody can bring their dog to the seat, and whether somebody next to them, might have an opportunity, the right to change seats if somebody brought their dog? That would be a small p policy. Another small p policy might be something more like on the University of Michigan campus. What type of animal support is acceptable so there may be, I understand there are various levels of animal support, some more for comfort and some really addressing need. And, you know, the University of Michigan campus has policy about what kinds of animals can be used on campus. I would think that would be a small P policy. There may be larger P policies that would have, I just don't know a lot about that particular question, or, you know, the content there. But I think what you're getting at is there are competing needs. Some of these might be in the sort of moral, ethical questions about competing needs, and others, there's my alarm for a break. Others may be more in the category of a law that would have regulations associated with it that would guide those decisions at a larger level. Does that help to answer that question?
I think so. If not, we'll get more from the person who asked,
Okay,
Keith Anderson, once we get back from break. We also
terrific.
have folks with their hands up, and so it's very exciting to see people getting more engaged and
Yeah,
coming up with questions. But I know we do want to have a break to stay.
yeah, let's have a 10-minute break.
track.
And so we'll be, looks like I could use privileges for screen sharing.
Okay, let me unshare my screen
Yeah,
so
that's
that you
okay.
can do that again.
Thanks,
Welcome
everybody.
back. Thank you so much.
New and improved speaker for the symposium in a different room, closer to the router, etc. So we'll see. Appreciate the technical help over the break.
Great. I know we have, if you want to look at the question in the Q&A, and also there is someone with their hand up that Andy can help, I think, facilitate someone to come live to answer that question.
About the link in the agenda, great. Social Security bureaucrats. How do you move past middle managers and department heads? Yeah, so that's a big question. I think that I would ask you to think about what it is you're trying to have an impact on. So in a few minutes, we're going to talk about policy levers. And in fact, my very next slide is sort of a complicated model of public policy making, and see if you can see in this model where it is you'd like to have impact. So rather than thinking about sort of an individual person who may not be helpful, I think what you want to do is think about the process and the sort of levers in the process that you can impact. So I'm going to see if I can.
And actually, before we go on to that next slide, can we get the question from Karen before we move on and jump into, you know, these critical questions of levers?
Yes, I don't see a question from Karen in mine.
She had her hand up in
Oh, great.
from the attendees, so that's
Karen, you can speak freely. We can hear you.
Oh, hi, everybody. I apologize. I think I inadvertently depressed the raise, but I did have a comment in the chat, and that was to address the issue that was being discussed prior to the break about the policy making and what criteria is used to make those decisions for persons who need assistance of some type of services from Medicaid. And so I was, if you'd like to read that, that'd be great.
So for criteria for accessing services in Medicaid, in the Medicaid program, is that what you're asking?
It was a comment that I made. Are you able to see that? I put it in just before we took the break.
For some reason, I'm not able to scroll. I just have
Yes.
one open comment, but yeah. Can
Nancy,
somebody read that?
it says, just a comment, remembering how challenging it was to get my prosthesis approved by Medicare and hoops which were in place before it happened was a real ordeal.
Yes.
in that the decision makers determined who would get a device and what qualified them.
Yes. Right. So if that was a policy that you were interested in changing or have it, you would have to find out where the policy is. Is this written in the Medicare law about durable medical equipment or other pieces of the law, or is this in the regulation that was written by CMS that talks about how to implement the law? Is this something closer to home, like Medicare Advantage or Medicare Select policy, coverage policy? You have to think about where it is that the barrier is, and then who are the policymakers that could change that language in the guideline, in the law, wherever that barrier is. I'm not familiar enough with coverage of prostheses in Medicare to know exactly. But yes, very frustrating, a great example of some place it sounds like you'd like to have impact, and maybe even think about bringing some evidence to bear when you want to communicate with the policymaker there.
I think I might like to do something of that sort. Thank you.
Yeah, great. Thank you.
Thank you.
Moving on, this is a complicated model, but if you're interested, you may want to spend some time in this model thinking about processes. So if you'll start in the box on the left called policy formulation phase, this is thinking about the agenda setting. What are the problems and what are the possible solutions to that problem? And what are the political circumstances in which we're working? That's a really important piece. And that helps you really think about, where's my policy window? Where's my opportunity to develop legislation or write a change to existing legislation. There's an implementation phase that really, as we said, has to do with things like, once a law is passed, then rules and regulations are written, and then the policy is operationalized, and then that policy exists in that circle on the right. There's feedback. So whatever the policy is in Medicare that covers prosthesis, it's not working well for people who need it. So there's some feedback that goes into essentially a policy modification phase. And then that modification phase starts again in policy formation. So this is just a way, another way to think about policy making. I don't think we need to spend any more time on it, but I provide it for you because I think for some people, it's another way to think about, where are my opportunities? What do I need to know in order to have impact? Okay. So in terms of legislative development, as we talked about, legislation is often constructed by this iron triangle. Sometimes, importantly, legislation is actually drafted. The actual words that they start with for the formation of a law or regulation are often drafted not by legislators and the lawyers who work with them, but by interest groups who want to say, this is how we think this should be written. And if you can go to your policymaker with something in writing that is the end point that you'd like to get to, it's a real bonus. Can't always do that because it isn't always clear exactly, or we're not all lawyers. We don't know exactly how to write these changes in. But and just a point I want to make about the fact that oftentimes policy windows are there are long periods of time between when people want to impact change and when change is actually made. I worked in Washington, D.C. in the 90s, in 1990, under the Clinton administration, and poured my heart and soul into reforming the healthcare system, which did not come to fruition until really until 2010. Under the Obama administration. And this work didn't start in the 90s. It started well before that. So just understand that sometimes it takes a very long time for policy change. Other times, especially in small P policy, sometimes things can happen more quickly. Occasionally in big P policy, change happens very quickly too. Sometimes when there's a turnover administration, if there's a certain priority, sometimes things that have been sort of languishing for a long time suddenly get passed. So legislative development is a process. In this slide, I'd like you to think about this sort of in 3 columns. So we're talking now about state level policy, and my organization chart works a lot at the state level. We do work at the federal level and the local level as well, but a lot of our work is at the state. And I just want to reiterate sort of the state picture of what we've been talking about. So our executive branch, the governor, she has her own policy team, and she administers the work in 19 departments. Many of them impact health. So I think we all think about the Michigan Department of Health and Human Services that Elizabeth Hertel runs. But we also have LARA, the Licensing and Regulatory Agency. And so just this morning on the radio, I heard that physician's assistants in the state of Michigan are trying to expand their scope of practice. They would like to have the legal ability to be called a mental health provider. What's happening is in our state, as in most all states, we don't have enough mental health providers. Physicians assistants see a role for themselves. They believe, their organizations believe that their training has equipped them to be mental health providers. And so they are asking for a broader scope of practice. That's something that Laura in the executive branch is going to administer if that change is made. That's where all of us who have licenses to practice in healthcare have our license. We also have DIFS, the Department of Insurance and Financial Services. That's where commercial insurance is regulated at the state level. And so if I'm Blue Cross Blue Shield of Michigan and I want to hike my rates next year, I have to file my intention to hike my rates with DIFS. And then DIFS goes through a process to approve or not approve my rate hike. So the executive branch has impact in those ways. Our legislative branch, just like at the federal level, we have a House and we have a Senate in Michigan. We have Winnie Brinks, who runs, she's our Senate Majority Leader because the Democrats are in power in the Senate. There are 38 of them. You'll see that only 20 of them are Democrats and 18 Republicans. So it's actually a pretty thin margin. It's the first time in 40 years that the Senate's been controlled by Democrats. And in the House, we have Joe Tate, who is the Speaker of the House. He represents part of the Detroit area. The House has a lot more members in it, but look at how almost evenly divided our current distribution is between Democrats and Republicans in the House. Another point I want to make here is that 54 of our House members are new. Why does that matter to policy? What that means is there are a lot of people who need educating about what the issues are in health today. And because of term limits, we have a great deal of turnover in our state. We adjusted term limits a little bit in our last election. It used to be that you could serve 3 two-year terms in the House and 2 4-year terms in the Senate. Today, you can serve 12 years in any distribution of House and Senate. But nonetheless, we have term limits, and this means that people turn over. It means that lots of people, every time we have an election, lots of people need new education. And so think about that as a researcher who has evidence that you want to share to have impact. It's a lot of work to go in there and educate. And in fact, what happens is we have lobbyists who turn out to be the educators of our elected officials because largely because of term limits. And then, as we talked about, not quite as much opportunity to have impact in the judicial branch in the way that we're talking about this. Any questions there? see if I can. Boots on the ground. I see Leslie, I've been boots on the ground for a while, worked my way from local to state to federal government, still having difficulty working through the systems for change. That was for one program, and there are many. Yep, really complicated, but Leslie, you could be a real asset to the people you work with. If you've had experience at local, state, and federal government levels, you can really help the people you work with to understand where their opportunities are for having impact. Okay. Let's move to our next slide. Just want to show you a couple of photos and of the people who have particular influence in the Michigan state government. So in the House of Representatives, Julie Rogers is the chair of the Health Policy Committee. And so she represents the Kalamazoo area. So if you were going to talk to her about an issue, you might think about, boy, is there anything I can do to bring in some evidence or perhaps a story that would have to do with any of her constituents in Kalamazoo? Representatives are very, very tuned in to their district. And anytime you can bring both evidence and perhaps a story about something happening or demonstrate how something is happening in their district, you can have a great deal of impact. On the Senate side, there's also a Health Policy Committee, and it's chaired by Kevin Hertel. You may have heard the name Hertel a few minutes ago. His sister-in-law is Elizabeth Hertel, who runs the Department of Health and Human Services. His brother, I believe, is married to Elizabeth. He served in the Michigan, I believe both the House and the Senate. His father, Curtis Hertel Sr., also served. In fact, he was the Speaker of the House in Michigan many years ago. It's important to know that Kevin Hertel, if you were going to go and talk with him about an issue, that he is probably very well steeped in the processes, probably knows a lot about who's who and who else has influence. Elizabeth Hertel, side note, also worked in a Republican administration. So she's somebody who we saw during the Snyder administration, and also we see in a leadership position in the Whitmer administration. Yeah, Mike McKee. I see your hand up. I see your hand up, Mike.
Thank you. I've just had a quick question, just referring to the other slide, in terms of the influence from lobbyists. And
Yeah.
so the challenge of being able to provide drafts or suggestions to maybe provide a document to present to legislators. Certainly, it seems unfairly skewed to those who are more well endowed in terms of teams of lobbyists and money. And so this is unfortunately a huge problem with disability organizations. Many of them are very low budget. Many of them are also trying to cobble multiple organizations for one lobbyist. And so I was curious if you have any suggestions on maybe successes or examples for those who are, the small organizations influencing change.
Yeah. So thanks. I think that's a really important thing to think about. So of course, any kind of interest organizations that you can be a part of who may be well endowed enough to have their own lobbyist. This would be a very important place to bring your evidence and perhaps a one-pager and give that to your lobbyist and talk about what it is you'd like to do. Lobbying is a really important issue. I think you might just put on your individual citizen voter cap and think about whether you agree with term limits. Term limits are very popular. I think there's a very popular notion about, only having people in place who we think are doing a good job. And there's really not a lot of conversation about building institutional knowledge. Somebody who sits on a health policy committee has an awful lot to learn. It's a very complicated space, health and healthcare. term limits have a huge impact on what policymakers know. I think when you're talking about, how do under-resourced organizations have impact, some of what you have to think about is how to be creative. So if you want to have impact at the state level, you might say to yourself, okay, which committees are going to be considering the bill that I'm interested in supporting? And as a researcher or as a member of an interest group, you might say, does anybody, does the person who represents me in my district sit on any of the committees that have jurisdiction over this bill? And go to their coffee hour and say to them, maybe with a one-pager in hand, which we'll talk about in a few minutes, here's my concern. I understand I'm one of your constituents, and I understand that this bill is going to come before you. And here's the evidence that I'm building in my work as a researcher of disability issues. And I want you to have this evidence so that you can use it when you're making decisions about this particular policy. So you can work at an individual level, but you have to know an awful lot, who to meet with, when, what committees do they sit on. This is all public information when they have coffee hours and things like that. And believe it or not, coffee hours, members often just sit there with their cup of coffee and nobody comes. It's an excellent opportunity to go and talk to somebody, an elected member of the House or Senate during their coffee hours, because very often they're just hoping people will come and talk with them. You might have the whole hour to yourself. It happens. But beyond that, there are some other opportunities. So for example, and I'll talk about this more too, organizations that we work for have government affairs people. So there are lobbyists for the University of Michigan. I'll show some of this in a slide. Kim Ross at Michigan Medicine, it's her responsibility to do all kinds of government affairs for Michigan Medicine. She might be somebody that you could talk with, that you could provide your evidence to, and find out what's Michigan Medicine's position on this, and is she going to be having a conversation with somebody in Lansing who you could share this information with. So there are other ways. You don't have to hire a high-priced lobbyist in order to have impact, but it is really important to know where you can have impact and what your policy levers are. Does that help, Mike? Okay, great. I'm just going to move on. I wanted to show you this picture of Felicia Brayback, because this is a really interesting thing that's happened recently in the Michigan legislature. There's a lot of conversation about all the problems in the mental health systems across the country. Michigan is no exception. And Felicia Brayback is a psychologist, practicing psychologist, actually here in Washtenaw County. She was elected to the House, and because of the confluence of her election and all of the pressure that legislators feel to try to make improvements in the mental health system, they've actually created a new subcommittee of the Health Policy Committee in the House that is exclusively focused on behavioral health. I believe this is the first time this has ever happened. Felicia, who is a new member, is the chair of this committee because of her expertise. So it's really exciting. And so people who are working in the disability space may have a lot to say about how things are funded and how things function in community mental health in our communities, because of course the community mental health is paying a lot for the IDD services. And so we now have a special subcommittee. Felicia Brayback has for many years sat on the on our community mental health board. And so she is a very knowledgeable person. And so this is a super opportunity for people who want to help our legislators think about the funding of our community mental health systems. Okay, so that is not the slide I want, sorry. All right, so this, I'm going to jump to this slide, which is another sort of, it's a visual depiction of how we think about what influences people who make policy change. And you can take a minute now, you can look at it later, but what I'd really like you to do is think about which of these do you think are more important than others? Did you know that some of these actually influence policymakers? And do you see them as levers, as ways to communicate? So when we talk about advocacy, and I see social media here, it's really important to think in the advocacy space about how best to use social media, for example. So it's a complicated slide in that it has a lot. It has a lot on it, but I just wanted to share that with you, and maybe we could have more discussion about that later. I've been talking about policy levers. These are the places, obviously. Yes. Go
I'm
ahead,
sorry.
Michelle.
Actually, that probably, if you go back to the next slide, I think that sort of comes to a question that PF had, which in terms of what informs policymakers, and you know, they were specifically asking about what are the methods, videos, what is going to get that information directly to it. And it seems like with this slide, you're not just saying they not only get information, but how is it out there in a way that builds broader support or enhances awareness in the community, or reflects a broader community engagement than just a single person.
Yeah, great points, all of those. I think any one of these arrows can generate conversation about how to have impact, and you might see yourself in some of them more than others. It's just a nice visual way to think about each of these things. And if you can think about your particular issue, and which of these opportunities do you see yourself being able to take advantage of? That's great. Thanks, Michelle. I want to move along. I'm a little bit cognizant of the fact that we're almost at 11 o'clock, and I'd like to get to the information about our breakout session that you're going to need for the breakout session soon. So let me get through these next few slides fairly quickly. But really, a lot of what we've been saying up until now is sort of to help you think through, what are your goals for impact? What is it that you really want to do? Do you want to support evidence-based decision-making? Do you see a law or regulation out there that really is inconsistent with what the evidence tells us? I think researchers have a particular opportunity here to say, here's what the evidence is that I'm building in my work, or I understand from the broader literature, from what I know about how programs function. And so do you want to support a change with some evidence through a one-pager, through some testimony? We'll talk about a few of these things too. Is your goal for impact to improve the care of certain subpopulations of interest, to reduce inequities, as we were talking about earlier? One of the questions was just spot on here. Are you trying to increase coverage, like insurance coverage, Medicaid coverage? Are you trying to maybe boost reimbursement rates for services that you think aren't being delivered because the reimbursement rate is so low? Or other kinds of coverage or spending concerns? Are you interested in expanding scope of practice laws, as I was talking about with this morning on the radio, hearing our physician assistants who want to expand their scope of practice for who can deliver which services? So in this mental health space, for example, some states, I think 4 or 5 states, allow psychologists to prescribe psychotropic medication. That is something that most states don't allow, but these are states that are trying creatively to help address the issues of not having enough behavioral health providers. Another place is pharmacists can write prescriptions. So there's a lot, as you can imagine, there's a lot of lobbying going on from the physician organizations about whether or not expanding scope of practice for other types of providers is appropriate or what they want. So scope of practice laws are really interesting, and this might be a place that you know, you might want to be able to see caregivers deliver different types of services than they can deliver today, for example. And anything else that you might think about. You want to start to hone, I'm sure you've all heard the expression elevator pitch. You want to start to think about, how do I speak about my goal? And how would I do that if I had an audience of a policymaker? This is a slide that comes to us from Eileen Kostanecki, who some of you may know from the Institute for Health Policy and Innovation here at Michigan Medicine. When Eileen does her educational sessions, she talks a lot about how important it is not to be too broad. I think her expression is, you know, don't go in and ask for world peace. It's too broad. Don't go in and be so specific that you're telling the policymaker exactly what you want to have happen. So this example that she gives, all state legislators should consider passing laws by June 24, mandating only healthy food choices in school lunches and establishing new task forces to provide that guidance. Probably too specific if what you're trying to do is have an impact on the kinds of foods that our kids are getting in school lunches. She says you're really trying to think Goldilocks. You're trying to think about really what does your research indicate, and go in and talk with your policymaker about what that research shows. I see a couple more. Do I see a couple? I guess not. I thought I saw more questions. Okay. So this is just another sort of way to think about it. You have a message, you have a story or some data that you want to convey, and then you want to have in the policy world what's called the ask. And the ask, and most people don't think of the verb ask as a noun, but in this case, that's what we're doing. The ask is specifically, what do you want them to do about it? So your message, what do you need your audience to know? What evidence do you need to provide for them? What problem do you need to describe so that they can really understand why you're there talking to them? Connect that message or that problem specifically to your work. Bring a fact or bring a story or bring both, which is best. And then before you go to that person or that conversation, have your ask formulated. So what are the priorities of the person you're talking to? Are they going to hear your ask in the way that you're stating it? And what is their power to really have an impact and make change? So just another way to think about how you have a conversation with policymakers. Anybody have any questions there before I move on to engaging policymakers? I don't see anything in the chat, but let me know if I'm missing something. So let's talk a little bit about, and again, this talk today is not really about the advocacy process. This is really a little more focused on the policy processes and policymakers, policy levers. So I'm going to talk about that. These ways to engage policymakers can certainly be appropriate for advocates, people working in advocacy organizations as well, but we're thinking about it today in the policy realm. So these in-person meetings I was just referring to, finding the coffee hour that your particular legislator has available weekly or monthly or something in your area. That's just one example. Another example is to make an appointment and go in to a policymaker's office. I want to emphasize here, and you're probably going to hear it from me 3 times in this talk, you always want to work with your government relations experts at the University of Michigan, at Michigan Medicine, at IHPI. you know, you have, if you work for Michigan Medicine and you're a researcher at IHPI, you have access to a number of people who live and breathe policy work. They know all about who the policy makers are and their levers and their priorities, and they have their own set of concerns and messages and policies that they're trying to impact. And so you always want to talk with your government relations people before, as long as you're wearing your University of Michigan hat in any way. You don't, if you're going as a constituent in a district, you can take that hat off and you can go meet and talk about things from a personal perspective. But when you have your Michigan Medicine hat on, please work through government relations before you go and have that in-person meeting. And sometimes even before you share written information, you'll want to talk with government affairs and make sure that what you're doing is consistent with what our government relations experts are trying to do. They also can give you great tips about different things, who to talk with about your issue, whether your one pager looks like it's going to get its message across, whether there's maybe an opportunity to testify at an upcoming hearing, those kinds of things. So government relations, they're your friends. Don't go rogue, work with them. I've referred a couple of times to one pagers, or sometimes we talk about policy briefs. A one pager is 1 page long. And I will say that again, a one pager is 1 page long. And this is what we're going to focus on in our breakout group. I'm going to give you some examples of one pagers, and I want you to read them, skim them, look at them, and pick one to criticize. And by criticize, I mean both what's good about it and what's not good about it. And some of it comes to you very naturally just as you read it. It's very easy to read when there's some white space. It's very easy to read when there are some text and some graphs. It's easy to read when the ask is clear. And your whole goal is easy to read. You don't want, if you send somebody something that's super dense, that's 4 pages long, the chance that they're going to read it is very, very low. People in the policy space, you know, if you go for a meeting, you'll probably have about 8 minutes. 8 minutes is not a long time. And so the materials that you use and the materials that you leave behind, sometimes we make that a noun. We say, here's your leave behind. It might be your one pager. They have to be extremely well written. You want lots of eyes on it to edit it before you take it out and use it. We'll talk a little bit about op-eds, and we'll talk a little bit about creating testimony as well. So let me just say a few more words about this one pager. This is sort of the currency that people most often use when they're trying to have impact on a policymaker. It can be just an extremely effective tool. And I hope that at least one of the 3 one-pagers that you'll look at during our breakout session feels like an excellent tool, but you'll have to let me know if you think that's the case. One-pagers must be 1 page. You can put maybe references on the back. One of the things that's super hard for researchers who are trying to write a one-pager is that researchers who write it for peer-reviewed journals spend a lot of energy talking about all of the limitations of their study. Researchers want their peers to know that they can't make claims beyond what their data shows, etc. Policymakers don't want to hear about the limitations of your study at all. You have to keep that in the space when you're working with your peers and when you're in the space of creating evidence through the development of a peer-reviewed journal article, etc. Policymakers don't want to hear about the limits of your methods, so don't put it in a one-pager. They want to know, what does the evidence show? What do we know to be true? This is what policymakers want to know. So, and they want to know it very clearly. Don't use jargon. we get so deep in our spaces. So I haven't used this expression yet, but policymakers are an inch deep and a mile wide. And I think researchers often are a mile deep and sometimes an inch wide. And so our language is different. They're not going to know all the acronyms that you use every day that everybody else around you knows and uses. So no jargon, no acronyms, none of them. Spell them out wherever you can. Use a lot of white space, use charts and visuals. You know, different people learn differently, as I think most of us here know. And so both a visual and some text sometimes is the most effective combination. And then tailor it to your specific audience. So tailor it if you're talking to a legislator versus and you want to have impact on changing a law versus if you want to go talk with somebody in an insurance company about coverage for a specific procedure or something. So be sure to tailor it and include your contact information on that. You'll see at the bottom of one of the one-pagers, there's an opportunity to list your phone number, but only do that if you're going to pick up the phone. People today don't pick up their phones very often. So if you're not going to pick up your phone, don't put your phone number on it, but do have some contact information on there. So the particular predicament that we're in right now is that we're going to go into a 30-minute breakout session. Let's take just a couple of minutes and introduce ourselves. I'll just go around and call squares, or Mike, you could do that if you prefer. I would love it if I wasn't lead for the exercise, but I'd happily jump in if there are questions. So why don't you go ahead with that? So introductions, take a look at the 3 one-pagers, make a decision as a group as to which one you'd like to critique. And then probably makes sense to choose someone who can convey what the decisions the group has made when we all come back together and we talk about what we've done in our breakout session.
This is Mike McKee. I'm with the Department of Family Medicine, and I'm also part of the Center for Disability Health and Wellness. So let's go ahead and do introductions. And Nancy, I'm happy to help kind of coordinate this, so you don't have to worry about that. India, do you want to go ahead and introduce yourself?
Hi, good morning, everyone. My name is India Foy. I am the manager for the Center for Disability Health and Wellness. I'm relatively new to the University of Michigan and Michigan Medicine. My background is actually in public health and nonprofit and government. I'm excited for you all to join us, and we thank you for bearing with our technical difficulties today. I may be somewhat behind the scenes during this discussion as I'm jumping back and forth to screens.
Wonderful. I'm going to go in the order of those who have their camera on, but I will make sure everybody gets a chance. So I have Leslie Grubbs-King. Hello.
Yeah. Hi, how is everybody? I am from the National Institutes of Health. I work in the rehabilitative medicine department. I'm also a student at Drexel University, and yeah, I'm happy to be here today. I've been working in this field for a long while, boots on the ground as a regional program director for developmental disability services up and down the Eastern Seaboard. And so I'm so excited when I participate in events like this, simply because as Nancy pointed out, this work is not for the faint of heart. You'll be doing something for years and still be working on it. So I'm excited to be here and learning, with everybody and speaking with everybody today.
Wonderful. Next on my screen, I have Patricia Anderson.
Hi, I'm the Emerging Technologies Informationist here at the University of Michigan.
Wonderful. And next is Bonnie Didi.
I'm a metadata librarian at the University of Michigan Library, and I am focusing on the intersectionality between DEI and A, libraries, and the Center for Disability Health and Wellness. Thank you.
Wonderful. Next is Karen Larkins.
Hello, everyone. My name is Karen Larkins, as previously mentioned. I am a former student of the University of Michigan, Go Blue, U-M School of Music, 1980. And since then, I have transversed into several different fields of occupation, from a musician to what I am clinically doing now with clinical therapy. I am a counselor, licensed professional counselor, but I'm also a certified rehabilitation counselor. And I work primarily with persons with disabilities. And I am currently providing consultative services as well as advocacy services to assist individuals who are encountering some barriers with employment or stigmatizations associated with trying to manage, a lifestyle as a person who's living with a disability. And I'm currently just enjoying what I'm doing and enjoying learning more, and have enjoyed this seminar thus far. I'm looking forward to learning even more as we go. Thank you.
Wonderful. I don't have, oh, actually, okay. The next one is Suhas. Good to see you again.
Hey, Dr. Mike, good to see you as well. Hello, my name is Suhas. I am a student at the University of Alabama at Birmingham, and I was a part of the 2023 M Disability Summer Internship Program at the Family Medicine Department in the University of Michigan. And I also work for a Center for Independent Living in Birmingham, Alabama. I'm very interested in how we can translate learning from interacting with individuals and community members to policy change.
Wonderful. Thank you, Suhas. Next one is Alicia Garcia. I don't know if you can hear us or not. Just give a second. If we need to, we can move forward. But Alicia?
Hello. Hi, I apologize. I just had someone in my office, so I had to step away for a moment. My name is Alicia Garcia. I am a certified rehabilitation counselor. So I heard that there's someone else here that's a CRC as well, and I'm a limited license counselor. So I'm working right now on my LPC. I am with Oakland University, our Center for Autism Outreach, and I am the director of our outreach. And so I largely focus on recreational programming and skill building programming for individuals on the spectrum.
Wonderful. All right, the next one I have is Haley Miller. Okay. I have the next one here is Jamie. I think it's pronounced C's Black, is that right? Okay. I apologize, but I don't know the next name here, given that it's a different language. I don't know if that person can speak up. Okay. Last, sorry, in the chat, so Teddy Dorsett, the third, is unable to turn on his camera. I know him really well, so I'm gonna just go ahead and read it out. So he is a native Detroiter and fifth generation deaf individual, currently represents the Coalition for the Deaf, Hard of Hearing, Deaf Blind. He's a self-employed filmmaker and brand marketing specialist. So thank you, Teddy. I think that's everybody. If anybody else I forgot, let me know. Okay. So as Nancy mentioned, there is a link. I hope everybody has that link so we can take a look at these 3 examples. I believe we're supposed to just review them and let's have a discussion, an open discussion, so we can think about what's good, not so good, what's attractive. Nancy, is that correct?
That's correct. And I think it'll be maybe even more effective if as a group, you'll pick one of the three
Sure.
and really as a group critique that and then identify someone who can bring that conversation back to the larger group when we're finished.
Nancy, maybe I would suggest the next group have a different one. So do you want to go in order? Like we would do the first and then the next person does, or the next group does the second one. So we at least have some diversity. Or
We could.
That's a great idea. I can communicate that.
Okay.
Okay, so once this group chooses to focus on one, then you'll go over to the other group.
Yes.
Terrific.
Okay.
If
So
you're
we'll just
looking for the
focus-
link, you can find it in the Q&A section. PF Anderson has posted a request for pasting copies of links, and the document here should be the first one from Andy Brosius.
Okay. So for the group, let's go ahead, do the first one, sepsis, and then the second group will likely do the second one. Okay.
I wanted to suggest that we do the third one because I think it shows the greatest potential for change.
Okay. Yeah, that's not a problem.
So we're going to do the third one.
Okay. How about this? Why don't I, would people like me to briefly share so everyone could see it?
Yeah, that would be great.
Can people see this?
We
Okay.
can see it.
Just read it out for anybody who are not able to see this. This is a one pager, somewhat text heavy, pretty dense, but this is directed to the American Academy of Family Physicians using the super committee to enact a permanent solution to sustainable growth rate using accountable care organizations. So yeah, there's a lot of jargon in there for sure. I can see where there's some concerns. Background, the sustainable growth rate, SGR, fails to control Medicare costs, ensure access to care and promote quality. So I'm not going to read through this so that way we can all collectively read through it. If anybody needs assistance, let me know and I can go further. But it might, if nobody needs it, we can just read together and then open it up maybe in about 2 or 3 minutes for discussion. So everyone get a chance, and I'll scroll down slowly so everyone can see it. Okay, in a minute, we'll go ahead, open it up for discussion. So I have 11:49, so 11:50 we'll open it up, okay? Okay, I'm gonna close I'm gonna stop sharing so we can see each other a little bit better. So let's go ahead, open it up. I know some of you already heard my initial comments once I saw it. Being a little text heavy, lots of jargon. It is a rather dense document. For those who might not be familiar with what it's trying to propose, it could easily be one where you feel lost and maybe not so engaged. Others?
I can start. It does kind of everything she said not to do, where there's a ton of jargon. They're using acronyms. There's no visuals. The numbers aren't put in graphs or illustrations to make clear what they are. The numbers don't compare. They say this group does this wonderful thing, 29 of 32, but it doesn't say compared to who or what, or if that's good or bad. There's no, they've got too many points and not enough priorities, as well as the dense language. It's not plain language at all. And there's no real story underlying it or shaping what they put together. It's a really good example of how not to do a one-pager. So there's a lot of opportunity. I kind of want to, if somebody handed me this as a rough draft, I would go, okay, give me a week and let's have another chat about it. And then I would just dismantle it and rework it and put it back together, and then we could have a conversation about it. This is a starting point, not an end point.
I agree with you, Ms. Anderson. I was like, okay, I got to read this like 10 times to identify all of the different the language, the definitions, the acronyms, and all of that. Also, who are you appealing to? You're talking to, who, what audience are you trying to get? If you're talking to a politician, they're definitely not going to look at this. If you're talking to the policymakers, no, if you're talking to the stakeholders, I'm talking about the individuals that really need this change to occur, I don't think they're going to understand all of these different pieces, so yeah, it's a lot going on here.
I agree with that as well. In fact, when you gave the 1-minute warning to say that we were gonna review this, I was worried because I felt like I needed significantly more time than another minute to even understand what was happening with this. And in that same thought, well, if I'm not understanding this, who is going to understand this? And there are obviously people who are going to understand this, but I think that for a lot of us, we wouldn't understand, and it definitely there's lots of opportunities here for revision.
I agree with. Sorry.
No, go ahead. I'm sorry.
I also agree, and from my perspective, as reading it, am I reading it like a policymaker would, or am I appealing to another individual? And how much time would they actually take to gloss over this much information? And additionally, as a person who works with the deaf and hard of hearing as an interpreter, I would need to understand the terms that are being added to this content to be able to explain it to a person who might be deaf or hard of hearing, and finger spelling all those different words, and then trying to explain to them, well, the AGO means this or the ACO means this and that, and that would just require too much time to process as a person who only has a couple of minutes to read through this and then try to explain it to a person of another communicative language. It would require much more time and study to really discern and decipher everything that's included in that content.
Also, too, when you start talking about money, cost cuts, 600 million, billion, and all of the numbers in here, you start to panic a little bit. Like, what does that mean? How does that impact my benefit? And overall, how is that going to impact the program when you start talking about big things like this? So it's almost a scare tactic. That's what it presents, depending upon what audience you're talking to. So, in a political, it's so polarized now. There's one side of the house might look at the money. There's another side that's looking at the laws and the impact of those laws on the money. So that's another thing that I noticed about this document.
I'm just going to jump in here and read Teddy's comment in the chat. Teddy says, I literally had to Google words to understand this as well and can relate to your feedback.
This is Patricia. What I kind of want to do is repackage it as what's the problem? ACOs are a solution, but first, what is an ACO? And then how do ACOs solve that problem? Just, what do we want you to do is maybe the last box. Please support accountable care organizations or whatever the legislation is that they wanted approved.
I think by doing that, Patricia, you could have several different documents, one-page documents.
For different audiences.
I wonder also if a comment can be made on the specificity of the ask. I know we talked about not being too specific or not being too vague, and I wonder if this is verging on being too specific in that it tells policymakers exactly what to do, as opposed to presenting the facts and then kind of offering a solution, but also leaving the floor open for like additional steps that could be taken on their part.
Can you identify anything that was done well in this one pager?
This is Mike. So there is quite a lot of information. Obviously, the individual seems to understand some of the challenges, but more the delivery is what the next step needs to be. I agree with the need for story, even having like an impactful quote, something to kind of hook them would be critical. But the individual who actually did this, I know it reads like almost like a legal fact-finding kind of document, but it is a complicated problem, which does make it a little more challenging. But it seems like the individual does have Bakery has already spent quite a bit of time in this area to understand it, but just needs help to deliver the message.
I would agree with that. And one of, I do a lot of work with healthcare comics. And one of the things we always have as a problem with people who are doing the first time they've done one is they want to put in too many words. They want to have too much dialogue. And they don't know how to let bullet points or images carry part of the story, and that when you have an image, you don't need to duplicate the words or describe or explain the image. And I feel like this person has kind of the same problems, where in the first part, they say 30% physician payment cut. And they have 3 lines around that, but the real take home is 30% physician payment cut. And they don't need the rest of those words. They need to really get rid of a lot of the words. So they've got good ideas. They just need fewer words around the good ideas.
And I also found that I as I glossed through the first time initially, I wanted to go back and try to get some more of the contextual information that was provided. And of course, in those couple of minutes, there wasn't adequate time enough to really break through or work through all the bullet points and the explanations. And I tend to be try to be more on the narrative side, which can also become quite lengthy in dialogue because you want to explain everything. And you want to delineate all the information that's necessary, that we feel is necessary to provide for a person to get a clear understanding of what we're trying to convey as far as information goes. So the lengthiness of a document of that type can take on a more, instead of being persuasive, it can just become more narrative. And then you lose a lot of the information and all the wordiness of the dialogue that's included.
This is Mike. Julia, there's a couple requests here for a stream text link. If you could put that in the chat, I think that will help. So we're not kind of pivoting back and forth. There is a link. Thank you, Julia. There's a link here for those who want to click and have it on a separate window. Should be all set. Thank you.
Mike,
Hi.
could you copy that, or Mike or Micah copy that to the Q&A, because the links in chat cannot be copied.
You'd have to copy it to a separate document.
Yeah, I have added that under the under PF's initial question. Can you please paste copies of the links here? So it says stream text link. It's the fourth answer.
I think the task now is to identify someone who will report back to the full group about your takeaways from this exercise.
Do we have any brave souls?
I can do it.
Okay, so we do have one that's brave. Okay.
Thank you.
Patricia, yeah. So why don't we just summarize to make it easier for Patricia, though? So we heard a lot about the complex terminology, the jargon, very dense, text dense, difficult to read to the point where there was recommendations that or suggestions that I almost need to clarify what they meant. There was also sense of the dollars being presented being overwhelming. Any other things to summarize for Patricia? And also the lack of a story, some way to just be able to understand the impact, have that emotional tone, I think would be helpful to hook them.
Also, too, the fact that they provided so much information, it was very good. The information is just, it will take some time to go through that document, you know? And so while they did provide a lot of information, just focus on a few points or the most important things that you want to get across.
Thank you. And Patricia put in the chat, so jargon, text dense, unfamiliar terms, acronyms, lack of a clear problem statement, lack of a story, lack of graphics, need for plain language, good information, just not well presented. I think that's a good way to summarize it. Thank you.
As people are changed again, from the one to another. And we are looking at there, we definitely are beginning to have some of the ones now from the other breakout rooms. So
Great.
So however you want to start us out with this.
Okay, here's what I'd like to do. I'd like to, if we could identify the person from each room who is going to share, and just to recall, you were given an example of 3 one-pagers. These are real one-pagers. I think I neglected to mention. That may surprise some of you, but and each group chose one then to talk about what's good about it and what could use some improvement. And so I guess I'm not sure what to call our groups, but the group, Patricia, for whom you are reporting out, I wonder if you could start by telling which one pager our group analyzed and then share the output.
Unfortunately, my video is not cooperating, but let me go ahead anyway. Our group did the 3rd of the 3 one-pagers, and we identified that it had a lot of the, it included many of the things that Nancy had said not to do. It was very text dense. It used a lot of acronyms, unfamiliar terms, jargon. People were saying that they needed to literally go Google words and phrases to try to find out what they meant. There was a lack of a clear problem statement. There was no story that provided weight or context for the problem. There were no graphics. There was a really big need for plain language. The information was good, but it was confusing and not well presented.
That's a good summary. Does anybody else who participated in that conversation want to add anything? Lots of opportunities with this one pager. A couple of things that I would say that if you were looking hard, you could see a couple of positives. They stuck to one page. That's a lot of information on one page. But when you're writing one pager, it's really important to stick to one page. It sounds so basic, but as researchers and others can attest, it's very difficult sometimes to, in a very clear way, convey complex ideas. And so I think another positive that was sort of mentioned in our group is that it's clear that those who wrote this one pager are experts. They have some real depth in what they're talking about. And so it's possible that that would be conveyed to policymakers. But for the most part, I think we'd put this generally in the ineffective category for all the reasons that Patricia shared. So thanks very much. Somebody, who's the speaker for the other room?
I know that we discussed both. I know Andy was going to talk about number 2, and then I was hoping that we would either get Michael, Lisa, or Ingrid to talk about number 1, or someone else if they raise their hand. But we
And
want
just to be clear, I think by number 1 you're referring to the sepsis
that's it.
issue brief, and by number 2 we're referring to the helmet law repeal.
Yes.
Brief. One pager. Thank
So
you.
I don't see anyone else jumping up and down to do number 2. So Andy, why don't you provide the summary?
All right. So yeah, we looked at number 2, and you know, we, after looking at number 1 first, we thought number 2. Oh, let me get on. Hello. So yeah, we looked at number 2 after number 1, and we thought comparatively number 1 was just knocked it out the park. We thought that was really great. The second one, it has some good information. When the title of it isn't quite as powerful of an ask as the first one, and we thought kind of it's just a little bit visually overwhelming to look at. There's good data here. It does, you know, discuss the impact, but we thought it could maybe be just a little
little bit more sparse to make it a little bit less dense to look at. And we discussed potentially, you know, the title, if this were something that was used for advocacy as well as policy, that might be why it's more neutral. But we really like the title on number 1 that kind of combined the impact of the issue and the ask in a very concise statement.
Yeah, I'm delighted that you picked up on that. You don't have to put the ask in the title. It doesn't always work, but when you can do it, it is so effective. If I'm a policymaker and someone hands me a 1-pager and the first thing I read is Michigan needs a statewide sepsis commission to avoid needless hospital deaths, I'm immediately curious. Why? What would a commission do? I might have to first ask, what is sepsis, which is solved in the little box just below the title, which is the ask. So it is a super effective way to start a 1-pager if you can do it. It's not a must, but it's a nice to have.
Can you speak a little bit about if there was a different purpose for that, or was it for the same purpose and background? Because that one seemed to be branded in particular by the University of Michigan entity, and kind of that ability to make that ask.
Yeah, so I don't know exactly how these 1-pagers were used, but I think the fact that you picked up on the idea that the audience isn't quite as clear as it could be, I think is an important takeaway. So if you are writing a 1-pager and you're thinking, well, I'm going to use it for 4 different reasons. I'm going to use it when I go talk to my legislator, a coffee hour next week. I'm going to use it in my class where I'm talking about the repeal of the helmet law. I'm going to include it as an appendix in this journal article that I'm writing. If you have really different audiences intended, it begins to show in your product. And so the point that we made earlier about the fact that you really have to vary these by audience, I think was picked up on by your group. And this helmet law repeal may have been as much about not really scolding, but saying to decision makers, look at the result when you repeal a law that is considered a public health good to many. Look what happens. There's a real impact here. So it could have been that the intention of this 1-pager was much more about sharing the data than it really was an ask. There may be a very implied ask of, let's return to our senses and have a requirement that people who ride motorcycles wear helmets. But it may not have been too. I think that it may have been used for multiple purposes. The sepsis 1-pager, to me,
and we had a good discussion on that too.
Yeah, would love to hear that.
And
because I think this is really what you should listen to, Arthur.
Right, and I know we had someone, Karen. Did you want to? Let's see if we can get Karen back on, and then I know from our group, Michael had a great point too. But Karen,
thinking as the conversation ensued about as a grant writer, how we have to make appeals, to individuals, funders, and make these NOVAs sound persuasive and convincing, and we need your money, or we like to have your money. And it's kind of the same approach that we're using when we write grants. We're asking for something, but it has to be in context with the audiences that are listening to our appeals. So we might not be able to use the same type of grant approach or asking for funding from one agency or organization that we might use with another. And that may also hold true with these policymakers, holders, stakeholders, whatever, that we have to kind of fine tune our requests and our information in the context to make sure that we're reaching those people, the funders, in the places where they can be convinced or persuaded that this is what's actually needed, and not make it sound like, you know, a lecture or, you know, that like we're just kind of telling them that this is what they need to do. Thank you.
Great, thank you.
Any other comments or questions about these?
And I don't see anyone from my group having their hands up, but once again, the summary from the number one was that it was, you know, it hit the points, it told a story, there was the white space, the ask was clear, the impact of that, you know, what had happened when other states or other entities had done that, had formed a body in terms of a specific outcome of it was clear. They liked the how a complicated issue like sepsis was kind of drilled down to the most important pieces. The recommendations were maybe also add how sepsis really hits folks from underrepresented, underserved, and marginalized communities, and that specific concern, and the return on investment that would come from creating that commission. And so maybe summarizing it in that way.
Excellent. If you are going to write a one-pager, I recommend that you keep all three of these in front of you for different reasons. I think that all of you have touched on all the most important points. You know, I think that sometimes a commission is, if I'm looking for something to be critical in the sepsis paper, it actually may be in the recommendation itself. Sometimes a commission can be seen in the policy world as sort of a place to go and park something. The idea in this commission is that it would actually have an impact on hospital deaths by, you know, a whole variety of ways to address sepsis. But sometimes even calling something a commission may be not to your advantage, just because it really has this historical connotation that is not always positive. I was looking for something to say about the sepsis paper and looking for something to be critical of. So excellent. I think I'm grateful to all of you for sharing. When you take fresh eyes and you look at something that I've looked at many times, you raise some points that I think are really terrific and that I'm going to keep in mind as I go forward writing one-pagers as well. Let's move on. I want to talk just about a couple of other ways that we can work in the policy space, especially I'll talk a little bit about how to give testimony and a little bit about writing an op-ed, which are another couple of ways, and then talk a little bit more about meeting with officials. Everybody has seen somebody on the hot seat giving testimony in front of Congress in a way that's very uncomfortable, may even that person may even receive some badgering. You know, it can be conveyed as a very unpleasant experience. I think the vast majority of the time it's an excellent experience. It's a really great opportunity to take the time to introduce yourself as an expert in a field, to share evidence. So most often there's a bill being considered in a subcommittee, and the subcommittee decides that they'd like to hold a hearing to discuss the bill. And in part, what they're trying to do is get information from interested members of the public and experts. And so testimony at the federal level, so testifying before the House Ways and Means Committee or the Senate Finance Committee, these are almost without exception invited testimony, very prescribed processes. Your written testimony can be this long. Your oral testimony that goes along with it can be, 3 minutes, 5 minutes. You must submit the testimony, 7 days in advance of the hearing. And the legislators themselves, if they attend the hearing, are prepared to ask questions and gather information. I used to write testimony for the administrator of CMS. The administrator of CMS gets called to Capitol Hill all the time on the Senate side, on the House side, to talk about issues in Medicare and Medicaid. And it was a very prescribed process. She was invited more often perhaps than even she wanted to go and do that. At the state and local levels, let's talk about the state level. That's the most common. This can be by invitation or it can be by drop-in. Sometimes during a hearing, a committee will invite people in the room to come to the microphone and share information. At the local level, you've probably all also seen, or maybe yourselves have walked up to a microphone and then at a meeting of your county commissioners or other situations that are more local, and those are usually less formal. There's usually nothing written there to submit. So you have to really understand the jurisdiction that you're working within. You have to understand what the rules are, what the schedules are. But like at the state level, which I really encourage you to think about beginning, if you're not already, to follow legislation that has an impact on the populations and the issues that you care about in the space you work in. They have a clerk. Every committee has a clerk, and you can contact the clerk and get information about whether there's going to be a hearing scheduled on a piece of legislation that is something that you would want to have something to say, whether you would take some evidence to share, or if you would be there to tell a story that can also be very enlightening. So I will leave it at that, but you can see at the bottom here, you have to meet all those time limits, page limits, everything, and you really have to practice your testimony to be most effective. Op-eds are another really useful and sort of interesting way to have impact in the policy realm. Very often, an op-ed is by definition an opinion piece. And so you have to have a point of view. Like the Detroit News or the Detroit Free Press, when they publish op-ed, they have an editor who's, if not her sole job, one of her major jobs is to make decisions about which op-eds to publish. And she comes and talks to our policy fellows. Michelle, you may remember this. And what she talks about most is that the point of view has to be very clear. The argument that you're making has to be very clear. And so it's also important to say who you are so that the reader can decide if they want to pay attention to you. Are you a person of standing in this area? And you might say, I am a disability researcher, I'm a physician, I'm a fill in the blank. Op-eds also require really clean and clear and concise writing style, similar to what a one-pager requires. Just it must be edited and edited and edited. And every word counts in an op-ed in particular, I mean, in a one-pager as well. But it's a very concise writing style. So I would encourage you to go read a bunch of op-eds before you try to write one yourself. You'll see at the bottom here, there's a URL for just an excellent article that came out many years ago now. That is, it's a step-by-step how to write an op-ed, and it is really terrific guidance. Also, I just wanted to point out a really good op-ed anticipates the opposing argument and refutes it right there in their op-ed. So you'll want to find a place where after you've made your own article, you'll also say, here's how the other side may see this, and here's why it's better to see it from my perspective. You can reach a really wide audience when you publish an op-ed in a big newspaper, even as newspaper circulations are, of course, over the years have decreased enormously. They still have, circulation, and they still are places that policymakers and their staffers pay a lot of attention to. The Speaker of the House is Joe Tate, and he is from Detroit. So what is published in the Detroit Free Press and the Detroit News, no doubt will be communicated to Joe Tate, whether he reads it himself or whether his staffers bring it to him. So that's the kind of thing you want to think about. If you want to have impact on something in Grand Rapids, you might want to either write an op-ed for a Grand Rapids paper, or what you might do is say, oh, Winnie Brinks is the leader in the Senate. She's the Senate Majority Leader, and she's from Grand Rapids. I'm going to connect with her staff, either through a one-pager or otherwise, or maybe write an op-ed. It's a bit of a craft to write a good op-ed, and I think this is one place, just like with the one-pager, where I would say have lots of people lay their eyes on it and give you their comments and make sure they understand the argument that you're trying to make. But use that article or that URL that's down there. That's an excellent guide for writing op-eds. So just back to the point about meeting with elected officials, and I know I told you I would make this point many times, and so here I go again. Touch base with your organization's government affairs before you meet with elected officials. If you're going with your, for example, U of M hat on, don't do that without touching base. I think it's my next slide that will give you names of, well, it's a slide that's a couple down, but you'll see the government affairs person for the University of Michigan is Chris Kolb. Chris actually was an elected member in the Michigan House for many years. He was term limited out. And so the University of Michigan scooped him up as the head of government affairs. And so that he's someone who also has a staff who report to him. And so at the university level, it's his office that you would contact. At IHPI, if you're involved with the Institute for Health Policy and Innovation, you would probably want to touch base with Eileen Kostanecki. If you're work directly for Michigan Medicine, Kim Ross is our government affairs person. So you need to know who those people are in your institutions, and don't meet with elected officials until you talk with them. Do your homework. Figure out what committees these people sit on. Does that committee actually have jurisdiction over your issue or your program? And if you can, figure out what their priorities are. And again, if you can anticipate a view that opposes yours, you might want to share that with the elected official, why that other view isn't as correct as yours. And you are going to have a very short meeting. These people do meetings in 5 and 10 minute increments. You're going to have 8 minutes to succinctly tell them who you are and why what you're talking about matters. And that's why I refer to this one pager as a leave behind. You won't have time to sort of walk through your one pager, but what a really great series of events is talk to your government affairs person, have your meeting, and then leave behind an excellent one pager that reiterates the points that you're trying to get across and your ask, your particular policy change that you're trying to impact. Practice your conversation, just like you would practice testimony, just like you would practice talk that you're going to give, because you only have 8 minutes, and much of that is eaten up in niceties. Hello, and it should be hello and goodbye and thank you. Very important to include in your meeting with officials, but you want to recognize the fact that you have very little time and you have a very important thing to say, and so you want to get it out there concisely. So practice how you do that. And don't be discouraged if your meeting is with a staffer. In fact, I would argue it maybe is even a more important meeting when you get to meet with a staffer. They're more likely to read the one pager. They're more likely to be gathering information from the other side of the argument. And so you really want to just don't be discouraged if you expected to go meet with Winnie Brinks and instead you're meeting with her staff person, because you very well may have even more impact there. So we talked about this right at the beginning this morning, and I said that I would talk about it a little more. There is a difference between policy and advocacy, and it's really important to keep that in mind. Neither is more important than the other. but it is an important distinction that can sometimes get blurred. I have written here some generalities. So for example, policies might be focused on laws, rules, etc. They're often created by government. Actions are required to allocate resources, those kinds of things. Advocacy may be more about imparting an idea. It may be about, it may have a moral suasion argument there. You'll see that first bullet under advocacy is really an emphasis on values. This is not always the case, but as we try to distinguish between advocacy and policy, sometimes advocacy is somewhat less apt to emphasize the evidence and somewhat more apt to say what is right and what should be. So researchers often serve as subject matter experts for policymakers, and that's what I'm largely what I'm talking with you about today. In advocacy, it may be that you spend more energy building relationships, making, you know, a researcher might say, hey, I'm an expert in this area and here's my contact information. But an advocate might say, you know, thanks for your time today. I'd love to meet with you again next month and talk about this a little deeper and bring a little bit more information to you and help you understand what me and my group really are supporting. And it's a different way of having impact. And as I said, neither one is better than the other, but keep this in mind, especially if you're wearing a University of Michigan hat, for example. It's, you know, after you talk with your government affairs people, you can do your policy work, but the advocacy work is probably better left to people in government affairs if you have your University of Michigan hat on. If you take that hat off, advocacy is a great place, a great space to be working in. I think we have about 5 more minutes. Let me just, I think I had one more. I think I've already gone through the list of who's who at the University of Michigan. If you're from another institution, you would have a similar list of people. Just wanted to point my finger at a couple of resources that I think if you're interested in staying apprised on health policy issues, there are a bunch of resources out there that are great. Some of them are behind paywalls and others aren't. Sometimes, and I know we have somebody who works in library science with us. So for example, I'm giving you a suggestion that you might want to read Gongwer or Mears. These are every day you would get a push about the things that were happening in Lansing today. It's a great way to stay apprised for what issues are hot, what's going on in the discussion about, you know, auto insurance reform, etc. Gongwer, my organization subscribes to. Mears, I know that we can access through the University of Michigan libraries. And so don't be discouraged if there's a big price tag stuck on some of the resources you want, because there may be other avenues to access them. You know, lots of weekly information that's free from the Michigan Hospital Association. They have a Monday report. The Community Mental Health Association does a weekly update. So the groups that are important to you, see if they push out information in an organized way, weekly, monthly, daily, and see if you can obviously sign up for their listservs. There is a nice, something called the Citizens Guide to State Government. And I have a URL here for that that's free. And it really helps you understand what committees, subcommittees exist, and helps you think a little more about where you want to spend your time as somebody working in the policy space. And then there are a couple of really great free national resources. The Kaiser Family Foundation has daily updates on very important health policy issues. They do an awful lot of sort of not just national conversation, but also they break out the issues by state. So if you're interested in how something is impacting the state of Michigan, often the Kaiser Family Foundation will have a section that is really specific to states. The Commonwealth Fund, equally excellent organization. They might pay a little more attention to Medicare. Kaiser might pay a little more attention to Medicaid. You know, you'll learn these resources, but those are two free national resources that are really just terrific. I also just want to encourage you, now that we're at the end of our time, to contact me anytime. I'm really happy to help you think through an issue and how you might want to have a little bit more impact in the work that you're doing. So please feel free to use this information and contact me. Just let me know you were part of this symposium, and I'm happy to chat with you or provide more resources. So any burning last questions? I know we're at 1 minute left.
I don't see, will we be able to get the references and put up these slides on the website, or send them out with for folks who attended?
Happy to share them. Just
Wonderful.
Let me know how you'd like to do that.
Okay, thank you. This has been wonderful. You know, it just touches the surface about what the framework that we need. I remember submitting a 50-page congressional testimony, and they're like, "Can't you shorten this to 1 or 2 pages?" And it was like,
But that crystallizes the experience of researchers. Michelle, you are so deep. You have so much to share. You're so deep in your area of expertise, and it is really a new skill to boil it down to a policy relevant sort of shape, like a 1-pager. It's very hard.
And I guess the last piece would be some of the difference between the advocacy that we're supposed to do about an issue that we do the research topic on to provide knowledge versus actual lobbying. Can you, those are...
So here's what I would say.
Okay.
That is precisely what the conversation will probably go like with your government affairs expert. They will say, we are the lobbyists and here's what we do. You are not a lobbyist, and so you do not do this with your U of M hat on. Lobbyists have there's a definition in each state and at the federal level about who is and is not a lobbyist. And they're allowed to do certain things that most of the rest of us are not. And that's really important to know. And that's really where your government affairs person is going to help.
Okay, so to provide education and briefs, but if there's any doubt, check with the experts.
I would even check with them, even if you don't have any doubt. I would still say, go check with them and say, here is my intention. I'm going with my U of M hat on to share this evidence. I want you to know that, and I want to, you might learn that Michigan medicine has, the opposite take on something that you as an individual researcher have, and it'd be really important to talk with government affairs about how you can share what it is that you know, and you might even have an impact on the position of Michigan medicine.
And I think that is a great place to leave it. Thank you so much, Nancy.
My pleasure.
Once again, this is about having an impact, and that's what we want to do with our research. That's exactly what we want to do with our education.
So I have the pleasure of introducing Dr. Robyn Powell. We're really thankful for you being able to join us and share some insights. So I'm going to go ahead and just give a little bit of background for Dr. Powell. She is one of our country's foremost authorities on the rights of parents with disabilities. Dr. Powell joined the University of Oklahoma College of Law faculty in 2022, where she currently teaches family law, disability law, professional responsibility, and public health law. Dr. Powell's scholarship focuses on the intersection of disability law, family law, reproductive justice, and public health law. And she has a particular emphasis on examining how laws and policies affect disabled people's decision-making about whether and when to have children. Her work has appeared in many different journals. She is widely published in legal and social science journals. As a disabled woman, Dr. Powell has dedicated her career to advancing the rights of people with disabilities. For nearly 5 years, she served as an attorney advisor at the National Council on Disability, an independent federal agency that advises the President and Congress on matters concerning people with disabilities. Dr. Powell is also the principal author of the National Council on Disabilities report, Rocking the Cradle, Ensuring the Rights of Parents and Disabilities and Their Children. As a leading expert, she has been interviewed extensively by many different TV media outlets as well. In May 2016, she was invited as a speaker at the White House Forum on the Civil Rights of Parents with Disabilities. So thank you so much for joining us.
Thank you so much for having me. That was a way too generous of an introduction, but thank you. So I am going to go ahead and share my screen. All right, so today I'm going to be talking about ensuring access to care for all, disability and health equity. And just to give you an overview of what I plan to talk about today, I'm going to begin by discussing the legal landscape, that is, what laws relate to and protect people with disabilities within the realm of health and healthcare. I'm then going to talk about healthcare disparities and the support needs of people with disabilities. Then I'm going to speak for quite a bit of time about barriers to access. As we will talk about soon, disabled people experience countless barriers to accessing healthcare. And then, as Dr. McKee mentioned, I have a strong interest in reproductive health and healthcare, so I am going to spend some time focused in on reproductive health services and information. And I think by doing that, it will allow you to really get a good understanding of how barriers to healthcare really do impact people with disabilities. And then I'm going to end the talk by really discussing how we can improve care for people with disabilities. I want you to all leave having some ideas on what we can do to make health more accessible for people with disabilities. So there are 3 primary laws that protect the rights of people with disabilities in the healthcare system. The first is the Americans with Disabilities Act, or the ADA. And with respect to the ADA, both Titles 2 and Title 3 are relevant. Title 2 applies to any public entity, so a public hospital, maybe a state hospital or a city-run clinic, for example. Those would all be covered by Title 2 of the ADA. Title 3 of the ADA applies to any private hospital or healthcare facility or doctor's office or health provider in general. So between Titles 2 and Title 3, we can see that the ADA applies really to all areas of healthcare. The second law is Section 504 of the Rehabilitation Act. And Section 504 of the Rehabilitation Act applies to any entity that receives federal funding. And Section 504, therefore, really does apply to almost every healthcare provider, because both Medicaid and Medicare are considered federal funding. So we can see that, again, that there is broad coverage. And finally, Section 1557 of the Affordable Care Act is also relevant. Section 1557, again, it's very similar to 504 in that it applies to any entity that receives federal funding. So what do these laws say? Well, these laws collectively say that a healthcare provider cannot discriminate on the basis of disability. They must provide accessible communication, so ensuring effective communication for people with disabilities. They must ensure that people with disabilities have the opportunity to have equal access to all programs, benefits, and services that are provided by a provider. They also require providers to provide reasonable modifications. So collectively, these laws should and do really do protect the rights of people with disabilities within the healthcare system. And, I think people for the most part know about the ADA and the Rehab Act, but very few folks understand sort of that Section 1557 of the Affordable Care Act in many ways has some stronger protections. It very explicitly, for example, applies to websites for healthcare providers. It has some implications for telehealth. So I think that Section 1557 of the Affordable Care Act is an often underutilized law, and something that folks within sort of the disability rights world haven't yet fully realized just how strong the law is. So again, this is sort of the legal landscape. This is where we're coming from when we think about healthcare access and equity for people with disabilities. So despite these strong laws, which have existed for decades, the Rehab Act has existed since 1973. The ADA just turned 33 over the summer, and the Affordable Care Act is 13 years old. So we're talking about laws that have spanned over 50 years. And yet, despite these strong protections, people with disabilities continue to experience many significant healthcare disparities and really many unmet needs. And so while I could spend the whole day talking about them, I'm not going to do that, but I want to just give you some examples of what that looks like. So we know, for example, through lots of research that people with disabilities are less likely to access preventative services than their non-disabled peers. This means things like your, annual physical exam, for example. We also know that people with disabilities have higher rates of comorbid conditions. This might be things like high blood pressure or diabetes or things like that. And again, that is often because of healthcare barriers. Overall, people with disabilities have worse healthcare outcomes than their non-disabled peers. We really just across all spectrums just have worse outcomes. We also have worse oral health. And I think there's a lot of reasons for that, but one of which most Medicaid programs across the country do not provide very good dental care for people with disabilities. So that is one of the many reasons I think that there is really worse oral health. We also know that people with disabilities often experience higher rates of depression and anxiety. They also have greater risk factors, decreased exercise opportunities, and maybe things like that can really impact people's health. We also know that there are lower screening rates, such as breast cancer screening or pap smears. People with disabilities are just less likely to be screened for diseases. They're also more likely to utilize the emergency room for their healthcare. And I think part of that is we know that people with disabilities have difficulty finding providers that will provide us good healthcare. And so that if you do not have a good provider, you end up in the ER. There's also inadequate health insurance coverage. So people with disabilities are more likely to be on Medicaid or Medicare as their insurer. But even that Medicaid or Medicare is not great. A lot of providers will not accept Medicaid, for example, because the rates are lower. It also doesn't cover as much. So again, even if people with disabilities are, for the most part, insured, they don't have adequate healthcare insurance. And then finally, it's important to note that everything I've just said is even more problematic when we look at people who live at the intersection of disability and other marginalized identities, whether it is people of color or LGBTQ plus people with disabilities. They experience the worst of the worst disparities. And again, it's because people who are multiply marginalized really face even more barriers because of their status, whether it is their race or their gender or their sexual orientation. Again, so when we are thinking about healthcare and healthcare equity, we do need to make sure that we are considering the needs of the entire disability community. And that, of course, includes people of color and LGBTQ plus people with disabilities. I think despite all of this bad news, we did recently experience a win, the disability community. So several months ago, the National Institute for Health stated that they were not going to include people with disabilities as a health disparity population. And what that means is that public health has traditionally looked at disability as an outcome. And because of that, they have really framed all of public health around this idea that disability is something that should be prevented. And in turn, people with disabilities have not really been focused on as a group that experiences significant health disparities, despite, as I just said, the numerous disparities that people with disabilities face. So there was a lot of push for the National Institute of Health to include disability within what they call their disparity populations, which include, again, people of color, for example, and other marginalized communities. So earlier this summer, the NIH, the National Institute for Health, said they weren't going to include disability. They were going to continue not to. In turn, people with disabilities, disability rights advocates, organizations, professionals, etc., really pushed the NIH. There was a huge pushback, and in September, the end of September, NIH changed course. So they announced that they would, in fact, include people with disabilities as a health disparity population. And what this means is now there will be further funding and research into health equity barriers that people with disabilities experience. So this is a really important win. And I showed this article to just demonstrate that because the NIH has a whole statement on their decision, but they don't really credit the disability rights groups for their win or their change in mind. And I think this article actually does highlight really why this happened. It wasn't that NIH just had a change of heart. What the outcome is because of disability rights advocates. And it shows the power of when we work together, we can make change. So now that we've thought about people with disabilities and the health disparities that they experience, I want to now talk about why. Why are these disparities existing and persisting among people with disabilities? And I think the reason is that disabled people experience countless barriers to accessing healthcare. And while I can't talk about every single barrier, I'm going to highlight several today that I think will exemplify sort of the challenges that people with disabilities do face when seeking to access healthcare. So the first group of barriers that people with disabilities face are what they call physical barriers. So this is things like a lack of ramps, for example, a lack of automatic doors, a lack of accessible parking, lack of elevators, anything structural that makes the building physically inaccessible to people with disabilities. It also includes things like inaccessible medical equipment. An example of this would be, for example, an exam table that does not go up and down would be inaccessible for people of short stature or wheelchair users. And then poor signage and wayfinding can be another accessibility barrier. So as you know, this picture on the slide shows a woman in a wheelchair looking up at a flight of stairs. And this really shows that physical barriers in hospitals and healthcare providers really create significant impediments to people with disabilities being able to receive adequate healthcare. And so there has been a lot of attention on sort of how do we address physical access barriers. And it's important to note that all three of the laws that I mentioned at the outset, the ADA, the Rehab Act, and the Affordable Care Act, all do require healthcare providers to provide physical accessibility to people with disabilities. But unfortunately, despite these mandates, these barriers do persist. And as a woman with a physical disability, I can assure you that these really challenges make accessing healthcare really difficult. So the second type of healthcare barriers that people with disabilities experience are communication barriers. So in this photo, there's a woman using sign language with a doctor or healthcare provider of some sort, and then a sign language interpreter, presumably. And so again, this is really showing sort of the many ways in which the inability for people to communicate can impact their access to healthcare. So communication barriers are things like lack of interpreters, lack of captioning, alternative forms, for example, providing people who are blind or have low vision with digital forms instead of paper forms so that they can have their screen reader read them. It also includes things like ineffective staff communication skills. If staff don't know how to facilitate effective communication for people with disabilities, that can really impede one's access to healthcare. And then finally, inaccessible medical technologies and software. We are seeing a really strong rise in the use of technology for healthcare, particularly things like telehealth. And we're seeing at the same time many communication barriers, providers not providing effective communication, again, whether it's captioning or interpreters or something else. So communication barriers really do pose a really significant challenge also. I've spoken with countless deaf people, for example, who have been unable to, or who have been denied sign language interpreters by their providers. I've heard of doctors trying to communicate with notes. And again, if you don't have that opportunity to communicate with your health provider, you are inherently going to be denied really good and adequate health care. So the third one is really attitudinal barriers. And I personally believe that these are probably one of the biggest impediments for people with disabilities. And so this little cartoon is someone without a disability talking to someone in a wheelchair, and they say, "And when we want your opinion, we'll tell you what it is." And I think that really sort of exemplifies the experiences that people with disabilities experience, both within and outside of the healthcare system. We encounter professionals and others who just continue to have very biased opinions about us, baked into ableist views on people with disabilities. And so this really leads to sort of discrimination in treatment, including, providers just outright denying people with disabilities access, or really not seeking their input when treating them. It also results in long wait times. It results in lack of staff disability awareness training. I can't tell you the number of healthcare providers that just do not know how to communicate with a person with a disability. And then there are so many biases and misconceptions about disabilities. And we know from significant research that health providers are often the group that has sort of the most biased opinions or perspectives of people with disabilities. And this really does then in turn affect the type of healthcare that people with disabilities receive. So again, I strongly believe that attitudinal barriers are probably one of the biggest. And I also think that attitudinal barriers are the reason that so many other barriers exist. If providers are discriminating against people with disabilities, have really, biased opinions, they're not going to be inclined to want to make sure that their building is accessible or that they're providing sign language interpreters. So I really believe strongly that it all starts with these attitudinal barriers. Another type of common barrier that people with disabilities encounter are transportation barriers. And in this picture, there is or on the slide, there's a picture of a gentleman in a wheelchair, and he is trying to get onto a train, and you can see there's a large gap. And that really shows sort of one of these issues. If we can't get to the hospital or we can't get to the doctor's office, we're not going to be able to access healthcare. And so this really, we see transportation barriers such as a lack of accessible public transit. You have to live in certain areas in order to have access to public transportation. I live in Oklahoma, and there's very limited public transit. When I lived in Massachusetts, there was public transit, but you had to live in the city. And of course, that leads to then significant cost issues because it is very expensive to live in a city, which is where public transportation generally is. Now, states do generally have some type of paratransit option, but again, that is often limited to where you live. And usually paratransit only exists if there is a public transportation system in your region. So again, that can be a significant barrier. And even if there is paratransit services, they're often very bad. They often include sort of huge wait times. They'll leave people stranded for a significant amount of times. They don't show up. They're really late. So paratransit is not reliable either. Now, ride shares such as Lyft and Uber are also often very inaccessible. There's only a few cities that have accessible Ubers and Lyfts. And so if you do not live in those cities, you can encounter really, significant issues using them. And also, even if you're not a wheelchair user, you can have difficulty. I know lots of people, for example, who are blind, who have been denied an Uber or Lyft because of their guide dogs, which violates the ADA, of course. But these matters do really continue. And then the last, I think, significant accessible or transportation barrier rather is sort of the high cost of accessible vehicles. So when one does not have access to public transportation or paratransit or ride shares, the only other real option one can have is to have their own personal vehicle that is accessible. And accessible vehicles are incredibly expensive. I don't know how to emphasize just how expensive, but I have one and they are very, very expensive. And a lot of folks like us cannot afford them. They can be, hugely cost prohibitive. And we know that people with disabilities experience significant economic inequities. And so therefore, many people with disabilities can't afford to purchase an accessible vehicle. And again, these transportation barriers are significant because if you cannot go to the doctors, if you cannot go to a hospital, how are you going to access healthcare? And this is, again, another reason that I think people with disabilities do experience really substantial health disparities. As I alluded to a few minutes ago, another barrier that is worth considering is technological barriers. So in sort of the wake of COVID-19, we have seen really a rapid increase in the use of apps and really telehealth and remote monitoring technology. And unfortunately, these softwares and these technologies are not often accessible for people with disabilities. So here in this image, we have someone, I believe a doctor, using telehealth, it looks like on a computer. And really, we know that, for example, these softwares often do not play well with screen reader software, which blind people use. We know that often captioning is not available, although we've seen some improvement over the years. We also know that these software programs can be inaccessible, for example, for people who maybe have low literacy, maybe people who have intellectual disabilities. Again, there has not been a large focus on ensuring that these telehealth software programs are accessible for people with disabilities. We also know that often healthcare providers now rely on digital files and healthcare records, which again, can be really inaccessible for people with disabilities if accessibility is not baked in. And so despite really, I think, this huge and rapid expansion in the use of technology, people with disabilities are in fact being left behind. And that is really, I think, also impeding people with disabilities access and therefore causing significant disparities. And I think that we are, as we continue to see this growth in whether it's apps or tools to improve healthcare access, or just telehealth or other ways in which providers use technology to monitor our health, we are going to really need to focus on how do we improve technology so that people with disabilities can really enjoy the same benefits that their non-disabled peers experience. Another type of barrier to healthcare access that people with disabilities experience are really what they call policy barriers or programmatic barriers. And so these are things that are in addition to everything I've already talked about, in addition to communication, in addition to physical barriers, in addition to technology barriers, in addition to transportation barriers. And policy and programmatic barriers are things like inadequate health access and insurance coverage. So again, if people with disabilities receive Medicaid and Medicare, which many of us do, we know that these publicly funded healthcare programs do not often provide the most comprehensive benefits. Many providers do not want to accept them because of the low coverage rates. We also know that if folks receive private health insurance, so for example, my employer provides insurance, and yet my employer, their health insurance does not cover all of my wheelchair repairs. So earlier today, I had to have my wheelchair repaired, and I had to pay like $150 just to get my wheelchair repaired because, again, my private insurer would not cover it. There are caps on sort of what they will cover for durable medical equipment and huge co-pays with respect to that. So again, health insurance is an area where people with disabilities continue to experience pretty significant barriers. There's also just discriminatory practices. An example of this that we saw during COVID is really, these crisis standards of care, which included that people, if providers ran out of resources, they identified sort of populations that they would not provide healthcare to, and people with disabilities were within those populations. And that is really just the result of significant discrimination. We've seen similar issues with regard to transplants, for example, organ transplants, where providers are denying people with disabilities health organ transplants. And then I think the last one is really the one that, of course, as a lawyer, I think about a lot, which is the lack of compliance with disability rights laws. And I have found that healthcare providers, do not follow the laws, whether it's the ADA or the Rehabilitation Act or Section 50 and 57 of the Affordable Care Act. They don't comply with it. And I also don't think that they even necessarily know about these laws. And so, what good are these laws if they're not being enforced and they're not being complied with? And I think that is why these disparities persist and these barriers exist, is because there is this lack of compliance and I would say enforcement with disability rights laws. And just to sort of build off of that a little, the problem with our existing laws is that they are all enforced by individual complaints. So my students often, when I ask them in disability law, sort of what they think is the solution, how can we improve access for people with disabilities, they often joke that we need sort of the ADA police. And what they mean by that is we need mechanisms where people can be monitoring entities to ensure compliance with the law. But as the laws exist now, no one gets in trouble for non-compliance unless someone brings a complaint. So there's no one checking up on providers. There's no one checking up on hospitals. And so that is, I think, one of the many reasons that we have this lack of compliance. There's really no incentive for providers or hospitals to comply with these laws unless someone files a complaint. And so, how can we increase compliance is something we should all be thinking about. As I said, I wanted to use reproductive health access to really show you sort of what all of these barriers look like with respect to a specific area of health, and reproductive health is something that I feel very strongly about. So we know that people with disabilities encounter significant barriers to reproductive healthcare services and information. And so what does that mean? That means not just what we think of sort of as basic, OBGYN doctor's offices, but it means things like sex education. It means things like maternal health care. So we know that people with disabilities who are pregnant and experience poor maternal and child health outcomes, whether it is preeclampsia, whether it is low birth weight, early delivery, all of these things really impact people with disabilities. And I think that we also sort of see this maternal morbidity crisis really impacting people with disabilities. So again, reproductive health care, understood broadly as both services and information, really remains largely inaccessible to people with disabilities. We know that people with disabilities often don't receive access to contraception, or they are just denied sort of that decision-making. Sometimes people with disabilities will be forced to take contraception. If you think about the case of Britney Spears a few years ago, When she was fighting her conservatorship, one of the things she talked about is not wanting to use contraception anymore, and her conservator not allowing that. And so her example is just one of many. There's also just a lack of accessible medical equipment and offices, exam tables that are inaccessible, mammogram equipment that is inaccessible to people with disabilities. And because of sort of that, many people with disabilities just don't get adequate health care. They don't get annual exams. They do not get their annual mammograms. They do not get their annual pap smear testing. They do not get breast cancer screening. All of these things go on really not received because people with disability can't access this. There's also just really strong challenges finding knowledgeable and willing providers. So I do a lot of research on people with disabilities experiences accessing reproductive health care. And so often they talk about how they're sort of, they have to teach their doctors about their disabilities. Their doctors don't know anything about their disabilities. Pregnant people with disabilities are often considered high risk, not because they necessarily are high risk, but because their providers don't want to deal with them. And so they label them high risk, and then they have to go to a specialist. So it can be really difficult to find a reproductive health provider that is knowledgeable about disability and willing to learn and to treat people with disabilities. There's also just significant biases and misinformation amongst providers on things around sexuality and reproduction and parenting with a disability. People with disabilities are presumed to not be sexually active. They're presumed to not want to have children. And so providers often are the ones that are really carrying on these biases. We know that providers often encourage folks to be sterilized, for example. As a personal story, I can share that I have been offered, a hysterectomy multiple times by providers for no medical justified reason, but always because providers assume that I wouldn't want to have children because I have a physical disability. And so those biases do, again, impact people with disabilities' access to reproductive health care and cause really significant and poor outcomes. And then really just a lack of sort of broader resources and supports available to people with disabilities in the area of reproductive health care. And when we think about reproductive health care, I would encourage us to really take a very broad perspective. So it is things like, your routine exams, it's things like maternal health care and perinatal health care, it's contraception, it's mammographies or mammograms. It is also things like abortion care. It runs the gamut, and people with disabilities are denied in all of those different areas. And so, this is just one of the countless examples. I would also note that it affects everyone. So one of the projects that I was involved in a few years ago, we interviewed parents with disabilities. And so this wasn't just parents that gave birth. For example, in many instances, we talked to partners or disabled fathers, for example. The person that was giving birth wasn't the individual that had a disability necessarily, it was the other parent that had a disability, and they often also reported really significant discrimination. I talked to a deaf father, for example, and he had requested a sign language interpreter to be available in the delivery room while his wife was giving birth, and the hospital did not want to provide it. And really their justification was that his wife could interpret for him, and the wife was responded, I'm giving birth, I cannot be an interpreter also. And so that's just one example. And another example, we spoke with a father who used a wheelchair, and he was told he could not go into the delivery room because his wheelchair would be in the way. And again, this is an area where they were just trying to deny him. So when we think about reproductive health care, we have to think about sort of all the ways in which people with disabilities are deeply impacted. And reproductive health care, of course, then ties right into the, parenting and that right to decide when and if to become a parent. And so it's all really looped and bunched together and really critical to ensuring equity for people with disabilities. So then I've given you some really bad news, I feel like, but there are many options and ways that we can, in fact, achieve health equity for people with disabilities. And so I want to spend now sort of the rest of my time talking about what we do. What do we do from here? How do we improve health outcomes for people with disabilities? I think the first one is we need to ensure that health providers are physically accessible to people with disabilities. So are they complying with the ADA's guidelines? There are specific accessibility guidelines. And so we need to ensure that health providers are really in compliance with these laws and are physically accessible. And it goes beyond the elevators and, automatic door openers. It's also things like equipment. Is there mammography equipment accessible to someone in a wheelchair or someone who's of short stature? Are there exam tables adjustable so that someone who is of short stature or is a wheelchair user can also access the exam tables? So again, it's this idea of sort of making sure that buildings and providers' offices are physically accessible to people with disabilities. We also need to ensure and improve compliance with and enforcement of our existing laws. We have strong laws on the books. We have the Americans with Disabilities Act. We have Section 504 of the Rehabilitation Act, and we have Section 1557 of the Affordable Care Act. These are all really strong laws. And so we need to be thinking about sort of how can we make sure that providers are complying with these laws, and how can we ensure that they are being adequately enforced. And this is things like making sure that legal legal aid organizations are prioritizing healthcare. Disability rights advocacy groups are prioritizing ensuring healthcare access. And we also have other opportunities though. So something that recently happened is the Department of Health and Human Services recently issued a notice of proposed rulemaking regarding Section 504 of the Rehabilitation Act. And what this means is that they're thinking about and considering really updating their rules and regulations concerning Section 504. And there are some really great pieces within what they're proposing that would improve healthcare access for people with disabilities. It would address these barriers around medical equipment, for example. It would also address, technological barriers to healthcare, and it would actually improve the rights of parents with disabilities. So these proposed rulemaking really, I think, could sort of up that game and really improve sort of our opportunity to enforce these laws. And so I would encourage folks to look at the proposed rulemaking. It is available online, and think about really responding to it. I think this is sort of a once in a generation's opportunity. They have not updated the regulations since they were originally passed almost 50 years ago. And so this is sort of our first opportunity to really dig in on this. There are also ADA regulations that are being considered that would also address some of this. We also need to ensure that providers are really developing and implementing inclusive policies and practices. Are they considering the needs of people with disabilities when they're developing their policies? How are they including the needs of people with disabilities? Are they taking a cross-disability approach, recognizing that disability comes in all different forms? Yesterday, I did a presentation and someone had a slide on it that said, not all disabled people use wheelchairs, not all disabled people use guide dogs and canes. And that is so true, because when people think about disabled people, they often think about, sort of the more visible disabilities. But we need to ensure that policies and practices really are reflecting the needs of all disabled people and not just some. So this is another area. I think the next thing we want to think about is sort of how we can encourage health providers to leverage technology. Technology can be a great thing for people with disabilities. We have seen technology really allow us to participate in our world in ways that we couldn't before. And so as providers in health, the health realm more broadly is considering sort of how they can use technology more broadly, we need to be encouraging technology developers to really make sure that they're ensuring that their software is accessible for people with disabilities, and really encouraging providers to leverage that technology so that they can better treat people with disabilities. We also need to ensure that providers are providing effective communication for people with disabilities, really, making sure that they have interpreters, making sure they have captioning, making sure they are providing things in plain language for people maybe who have intellectual disabilities, really making sure that all communication from healthcare providers is fully accessible to and usable by people with disabilities. We also need to think about how we expand health insurance. The cost of healthcare is one of the most significant issues facing our country today. And for disabled people who are already economically disadvantaged, it really does affect us. So how do we ensure that health insurance is available for us and that it will adequately cover us? Which relates to sort of the next thing, which I think we need to really look at if we want to improve access to care, and that is addressing economic insecurity and transportation issues amongst people with disabilities. As I've said, people with disabilities are amongst the poorest in our society. Many are really forced to live in poverty, particularly those who receive SSI or SSDI. They receive very little benefits, and they have very strong and very strict rules on how many assets they can have. For example, if you're on SSI or Medicaid, you generally can't have over $2,000 in your bank account. So we force people with disabilities into poverty. And we know that poverty directly impacts one's health outcomes. It impacts the type of healthcare you can get. It impacts the world in which you live and sort of the risk factors that you are exposed to. And so if we are really truly caring about how do we improve care for people with disabilities, it starts with really looking at these issues around economic insecurity and very related transportation. We also need to ensure that healthcare providers receive training on disability. And this really, I think, needs to be training that is done by people with disabilities. Most disability awareness trainings that exist is really poor. And it's because it doesn't involve disabled people. But how do we ensure that people with disabilities can be in and involved in creating and executing this training? And it starts with, medical school training, for example, for future doctors, nursing school, any sort of medical professional should have training, not just in school though, but ongoing training while they're working in the field. We also, and I think this is perhaps the most obvious, but we need to expand the workforce of providers with disabilities. The best way that we can ensure that our needs are met is to ensure that the health field reflects who we are, that the health field has people with disabilities working within it. We need doctors that are disabled. We need nurses that are disabled. We need to really encourage the health profession to focus on opening its doors to people with disabilities. We also need to ensure that health providers are providing information that is accessible to people with disabilities. And I think lastly, we also need to think about how do we include, or rather, how do health providers engage with the disability community? So often policies, practices, rules, everything is made about people with disabilities, but does not include people with disabilities. And so we are the experts on our lives. We know what works, and we also know what doesn't work. And so the only way to truly improve access to care, to ensure that we are able to access the care in a non-discriminatory manner, is to ensure that we are engaged at the outset. If we are engaged at the beginning, we can ensure that entities are physically accessible, that laws are complied with, that policies reflect our needs and experiences, that technology is adequately used, that communication is accessible, that we can address these barriers around economic insecurities and health insurance and transportation. And we can ensure that providers are not only trained on disability, but also providers are in fact people with disabilities. And so really engaging with the disability community is so crucial to improving access to care. So one last thing I want to talk about is how I think we need to embrace disability justice. So we often talk about disability rights, but disability justice builds off of disability rights. And I think that if we take on health inequities from a disability justice lens, we really can address all of these issues that I've been talking about. So disability justice was created by disabled activists of color, and it was done in response to what they perceived as sort of the limitations of the disability rights movement. That really means that the disability rights movement has focused a lot on people who are physically disabled and really not people of color, for example, not people with intellectual disabilities, not people with mental health disabilities. So disability justice is created in response. And it really values what they call intersectionality, which is the understanding that it's multiple identities that affect people's experiences. It's people's disability, but also things like their race or their gender identity, their socioeconomic status, their sexual orientation, their economic class, sort of all of these factors impact people with disabilities experience. And if we are not valuing that, we are not going to achieve equity for people with disabilities. Disability justice also values interdependence, this idea that we all help one another and that is okay. And we don't have to be able to do everything for ourselves. Everyone is interdependent on one another, and that is something that we should celebrate. And disability justice really does value civil rights for all people with disabilities. And so if we are going to take health equities from a disability justice perspective, we are going to first need to prioritize leadership of those most impacted. This means things like making sure that people with disabilities, particularly people of color with disabilities, LGBTQ plus people with disabilities, are leaders in movements, are at the front of all of this. We also need to change narratives that perpetuate ableism, sort of these ideas that we are less than, with respect to reproductive health care, that we are poor parents, sort of, we need to change the stories, change the narratives. We need to ensure that buildings and providers are accessible and inclusive. We need to work with other groups. So if you go back to my example about reproductive health, for example, we can be working with reproductive justice groups. We should be sort of cross-movement organizing. We also need to be aware of sort of our histories and how we have excluded people from the movement and therefore have resulted in more health inequities. And we need to sort of promote solidarity amongst different social justice causes. With respect to sort of healthcare specifically, I think this means sort of one, critiquing the medical model of disability, which has seen disability as sort of the problem that needs to be fixed. The medical model of disability is really dangerous and unfortunately something that still persists within our healthcare system. We also need to listen to those that are directly impacted by access barriers. Again, this idea is that people with disabilities need to be at the front of all of this. We need to ensure that there is diverse representation in leadership and decision-making. We need to move beyond sort of compliance with legal minimums. The ADA should be the floor, not the ceiling. So while the ADA is great, for example, it doesn't really address all of our needs. And so really, we need to sort of be thinking beyond that. How can we really truly achieve access? We really need to, focus on sort of these community-driven solutions. How can community groups work together? And really, we need to address biased policies and practices through a justice lens, sort of this idea that the only way to achieve equity is through justice. So using sort of these ideas and these values, there are several things we can do. The first is we need to be supporting and amplifying the work of disability justice groups. Too often they get ignored within our movements, and I think we need to be amplifying them. I think we also have to have some really frank conversations on how do we challenge our own internalized ableism. People with disabilities are not immune from ableism, and we are deeply impacted by sort of these internalized ableisms. We also need to really encourage healthcare providers and agencies to join our efforts, join disability justice, promote disability justice. It's also, in order to really use disability justice to achieve this health equity, it's really important that we educate ourselves on sort of the activism and the writings of the disability justice movement. They are super interesting and so moving. And I think it's something that people really need to get familiar with. And then finally, I think we need to collaborate with other social justice causes on that intersectional advocacy. So for example, there is a lot of work being done on the maternal health crisis with respect to people of color and the very tragic poor outcomes that they experience. And I think disability should be involved in these because we know we are also amongst those that are really impacted by poor maternal health and maternal child and health outcomes. And so again, this is this idea that we need to work together. We need to work with other stakeholders that are interested in already working on this. There's power in numbers. And I think that really, if we take this disability justice perspective, we can finally achieve health equity, and something we've been trying for so long. But this could offer sort of that opportunity. So with that, a few other resources, just as you're thinking about sort of next steps in what you can do to improve accessibility in healthcare. There is the ADA National Network, which has, amongst other things, a fantastic fact sheet on sort of the ADA and what healthcare providers must do to comply with the ADA. It's really useful. The Centers for Medicaid and Medicare Services also has a very interesting document on how to improve care, access to care for people with disabilities. The Department of Justice also has guidance for how to ensure physical accessibility. How do we know, how can providers know that they are complying with the laws and ensure that they are complying? And then really also DOJ has some really new guidance on sort of non-discrimination in telehealth. And so again, this idea of how do we ensure that these new technologies such as telehealth is fully accessible to people with disabilities. So with that, I am going to, I think, end, and I'm happy to take on questions if we have time.
Thank you so much, Dr. Powell. That was really awesome. And I'm sure there's going to be a lot of questions. As we wait for people to go ahead, chime in and put their questions in the chat or raise their hand, I do have a question to kind of start us off. So early on, during your presentation, you mentioned the Affordable Care Act. In some ways, the Section 1557 could be even more powerful. Could you provide us a little more clarity about that, and also perhaps ways to initiate, because the struggles of getting things enforced, what are some avenues for us to think about so we can hopefully get better compliance?
Yeah, so the Affordable Care Act has been really tremendous for people with disabilities in a lot of ways. I think it's sort of celebrated amongst the disability rights community, but it really ensures sort of that providers, you know, for example, can't discriminate against pre-existing conditions. They can't have sort of caps on how much they'll pay for. It has done a lot, and Section 1557 is a non-discrimination provision, which again says that providers cannot discriminate against people with disabilities. And so how do we enforce it? Well, the Department of Health and Human Services Office for Civil Rights does enforce it. So you can very easily actually file a complaint with the Office for Civil Rights. You can go to their website, hhs.gov, and go to the Office for Civil Rights page. And you can, it's really simple to file a complaint online. I think it's free, so you can do that very easily. But also every state has a protection and advocacy agency that generally they're called Disability Law Center, and then fill in the blank of the state, but they have different variations. But you find your protection and advocacy agency, and they almost always do have a focus on healthcare access. And they can help to really ensure and really enforce the laws as they are. So if you experience healthcare barriers, whether it's physical access, programmatic, communication, etc., you should feel free to call your protection and advocacy agency and file a complaint with them. And you can file complaints with the Department of Justice. And again, that can be done very easily on ada.gov's website. Again, I know that this can be challenging. As a disabled person, I often think about if I sat all day and just filed complaints, I would do nothing else in my life. So I get sort of the challenges with it. But I think the only way to improve it is to really hold people accountable.
Thank you so much. There is a question in the Q&A. I'm not sure if you could see it. I can read it out. So Patricia said that after this morning's focus on policy, I'm really interested in where Dr. Powell sees the greatest need for policy change, update, revision, reimagining. Yeah,
that's a great question, and one I could take hours to answer, and I only have minutes. But I think we have to, when we are thinking about policy change, we have to really take a very comprehensive approach. I think so often healthcare access has been very siloed. So people are concerned about one thing. They might be concerned about medical equipment. They might be concerned about physical accessibility, entrances and stuff. But if people can't get to the providers, if they don't have the economic abilities or the transportation abilities, or there are language barriers, if we are not really addressing people with disabilities' holistic needs, we're never going to achieve health equity. So I think taking a more holistic approach, and that necessarily requires us to engage with disabled people. Disabled people are the experts, we're the experts of ourselves. So, talking with other disability justice and rights groups about sort of what their focuses are. And the last thing I would say is intersectional approach is needed. If we're not thinking about other identities that disabled people have, it's not going to improve outcomes for them. Just because we might be addressing the disability related barriers they experience, that doesn't mean we're addressing the racism they experience or the transphobia they experience or whatever it is that they're experiencing. And so the only way to really improve health equity is to take that intersectional approach.
We have time for a couple more questions. Anyone is welcome to type them in the Q&A or raise your hand and we can call on you to speak.
Oh, and a cat had a question I see now that I'm looking at the chat. So that's exciting. I've been hoping my dog wouldn't start barking, so that's good.
So Dr. Mead also said, can anyone file a complaint or does it have to come from the individual with a disability?
So it has to come from the individual with a disability. So the ADA, when you file ADA complaints, it has to be attached to some person. That is sort of one of the many, I think, limitations of our existing laws is sort of that idea that the person has to be attached. So it would have to be a disabled person that encountered some barrier. You could file with someone, you could help someone, a parent or whatever, but there would have to be a person with a disability that experienced that exact barrier.
So it looks like another one from Teddy Dorset. The third said, how does one prevent burnout? Method of the intersectional work if servicing more than one organization?
Oh gosh, self-care, I think that, that is something that I think we all sort of struggle with. And as a disabled person myself, it is something that I fully get. The only way you can really help others is if you help yourself. That idea that when you're on an airplane, you have to put the oxygen mask on yourself first. And it's really that the best way that we can really help others is to make sure we're taking care of ourselves. And I'm not saying that I have all the answers to that, because I think I sometimes struggle with burnout, but I think that sort of that focus on self-care is really critical. And being not afraid to ask for help and being able to say no. It's something I'm still learning, but being able to say no is a really critical part.
All right, we have time for about one more question. In the chat from Melissa, we have, how can we convince leaders to build beyond minimum ADA codes, which are outdated?
Oh, goodness. I think at some point, I think these sort of proposed ADA regulations and 504 regulations do have the opportunity to go beyond some of the existing, but also there's state advocacy that can be done. For example, I used to live in Massachusetts and we had our own accessibility code, which at times was better than the ADA's. So I think there's something to be said for state level advocacy. And I really think that that is one type of avenue, but also I think collaborating with health providers. When I began working as a lawyer, we did a lot of work where we would approach hospitals and really encourage them to get community boards, for example. So many of the hospitals in Boston now have boards of individuals with disabilities, sort of advisory boards on board. And so they collaborate, and the disabled advisory board sort of inform. And I think if you use those approaches, you can improve and sort of go beyond that floor of the ADA. But the ADA should be the floor, not the ceiling. And I think too often the ADA is sort of seen as the ceiling.
Thank you, Dr. Powell, for a wonderful talk. We do have, I believe, another question, but we're out of time. We do need to move forward. If you could take a look at the question and perhaps respond in the chat, that would be awesome. Again, thank you so much for joining us. It's great to see you as always. And so I'm going to turn it over to Dr. Mead to lead us through this series of research abstracts and presentations.
Thank you. Once again, really wonderful talk, Dr. Powell. I'm very excited and energizing. I think it really sets us up well for this next series of talks, many of which do focus on access for individuals with disabilities to various settings. And so I would like to invite Sahas Kalampala to come on the line and to call up his presentation and do a quick introduction and then move forward. Of note, we have a break at about 2:45, 2:46, and we'll have a discussion of all the abstracts and presenters and how all these connect together at the end of the day, starting at about 3:20. So.
Good. So firstly, I just want to thank CDHW for the opportunity to present research, and also thank you to Dr. Powell for the fantastic presentation before this. My name is Suhas. I'm a student at the University of Alabama at Birmingham, and I was a 2023 summer intern at the M Disability program in the Family Medicine department. And this is research that was conducted as a part of that program this summer. And it was conducted under the IDEAL RRTC R4 grant. And specifically, the project focuses on the feasibility of a best practice advisory designed to increase preventative care amongst individuals with physical disabilities. So first, a little bit about the background. So individuals with mobility disabilities make up 12.1% of Americans, and they experience a higher mortality rate as well as greater prevalence of morbidity and multimorbidity for both psychological and physical conditions. And primary care is uniquely situated to address some of these disparities because of its focus on disease prevention and health equity. But there is a need for ensuring that healthcare professionals are aware of these unique needs that people with physical disabilities have and address these health needs as well. So the aim of this study is to assess the feasibility of a best practice advisory that prompts providers to conduct preventative screening for conditions that people with physical disabilities are more likely to develop, thus addressing some of the health disparities for this population. So now going into the methods. So first we'll take a look at the intervention itself. So this is a best practice advisory which prompts screening for certain health conditions that people with physical disabilities are more likely to develop. And this includes the DEXA scan to screen for bone density, renal ultrasound, hemoglobin A1C to screen for diabetes, and so on. One thing I'd like to point out is that the study included a specialized social worker who was trained and experienced in addressing the unique psychosocial needs that patients with disabilities have. The provider, when faced with this BPA, has three options. They could either place an order for the suggested screening, they could dismiss the BPA with an explanation, or they can ignore the BPA altogether. The BPA is triggered in the presence of two criteria. One is the presence of a diagnostic code that's relevant to physical disability, and simultaneously there needs to be a lack of prior screening for one of those conditions within a recommended time period. Now, a little bit on the data collection and analysis. This was a mixed methods study, and on the quantitative side, the data came from a BPA usage metrics that were obtained from the health records, and this includes the number of interactions that providers had with the BPA, the breakdown of which orders were placed, as well as the type of providers who were placing these orders. The data that's presented today has been collected since September 2021, and the main analysis done on this was descriptive statistics. On the qualitative side, there were 2 interviews conducted so far with physicians who use the BPA to get their experiences on various aspects, including successes and barriers to using the BPA, their confidence in making use of the BPA, and their recommendations to improve the implementation. One interview was chosen to be open coded, and subsequently a code book was developed, and that code book was then applied to both interviews. The consolidated framework for implementation research was used to analyze the implementation and to identify some areas for improvement. And this framework combines key ideas from several implementation theories, and this includes characteristics of the intervention itself, as well as the organizational characteristics and the characteristics of the individuals who are involved in the implementation. Now we'll move on to the results. So there are multiple themes identified, but we'll focus on 2 main themes. The first is competing priorities. So on the quantitative side, we see that the BPA fired a total of 1,506 times, and it was addressed 159 of those times, so approximately 10.6%. And on average, providers interacted with the BPA 7.4% of the times that it fired. So we can see that the usage is not very high, and the qualitative findings kind of offer some potential reasons as to why. So one point that was mentioned by the providers is that the focus of the visit is important. And so if the visit is scheduled for chronic illness management, they're not very likely to bring up the BPA and discuss the orders. They also described insufficient time with the patients, particularly that reviewing the chart to make sure that these screenings are needed can take time, and that's also a barrier. Providers also described that they had competing priorities with some other BPAs, and the large number of BPAs kind of makes it difficult to address each one of them. And kind of as a point to build off of that is that these other BPAs are tied more closely to performance metrics of the physicians. And so they're more incentivized to use other BPAs compared to the PWPD BPA, which lacked such an incentive. The second theme is provider knowledge. So if we look at the quantitative aspect here, we see a graph which represents the number of orders that were placed for each type of order. And we see that some orders have more usage than others. We see that the social work referral had the highest, followed by the hemoglobin A1C and the lipid panel. And there were others which had a lot lower usage comparatively, including the bone density. And once again, the qualitative findings provide some explanation for why this is the case. And we see that the providers were more comfortable screening for lipid and the hemoglobin A1C and other blood work. And they could understand the rationale behind why they would need to do that. But for the bone density, it was not as clear why it was recommended for patients with disabilities. And that could possibly be a reason for why there is a low usage for that particular screening. And providers also wanted to know the reason for BPA firing for a particular patient. So presenting them with that information of which diagnostic code caused it to trigger could increase the usage as well. Some additional themes, providers felt that the BPA did have some benefit, and it would have enhanced benefits with some improvements that they suggested. Providers also felt that the social work referral was beneficial in being able to provide some specific resources and services. Yes.
Rebecca from CDHW. I just wanted to let you know, you have a couple minutes left, so if you want to do a couple Q&A, I'd suggest doing that soon.
Actually, Rebecca, we have 1 minute and then we move on to the next person. So, and Q&A is at the end. So
Q&A for the end?
That is at the end. So
Q&A.
Just finish up, Suhas, and then we'll move on to the next presenter. Thank you.
Gotcha.
Thanks.
Gotcha. Thank you for that reminder. And just really quickly, a recommendation. Providers recommended that patients be advised on why these screenings need to be conducted to encourage follow-up and completion of these screenings. And they would also like to know the specific services that were offered by the social worker, which go above and beyond the regular services offered by a typical social worker.
Okay, any final words?
That should be all. Next steps include performing more interviews and modifying the code book accordingly.
Okay, thank you so much. We look forward to asking you questions when the discussion point comes. And moving on to our next panelist, Tome Lawal, I believe, please correct me if I pronounce that wrong, presenting the case for the Adaptive Sports and Inclusive Recreation Initiative.
Thank you, Michelle, for the introduction. That is a correct pronunciation, which is rare. All right, I'll just start then, I guess. Good afternoon, everyone. My name is Tome Lawal. I'm a medical student here at the University of Michigan, presenting on the case for the Adaptive Sports and Inclusive Recreation Initiative, or ASIRI. And I am presenting this on behalf of the Adaptive Sports Research Collaborative. Sorry, because of the acronym ASIRI, you might hear my iPad talk. This has been an ongoing issue that we've had, but hopefully it won't be too disruptive. Also, for people who might have any visual impairments, I'm a 25-year-old dark-skinned Black male wearing a blue suit, red tie, and a white collared shirt. So I'll start by giving just a quick overview of what the talk will include today. It'll be an introduction, just kind of reviewing the problem as our team saw it and the case that we're trying to make. Methods to give an overview of the ASIRI curriculum. Our results that we found from the study to kind of explain some of its impact, and then our conclusions and takeaways for future work. So to start, I want to characterize the problem, which we found to be that Michigan does not have a physical education curriculum in the public school system that ensures equitable access to physical activity for disabled youth. As a result, this leads to a disproportionate number of disabled children experiencing obesity and lower levels of fitness. And this is an issue that we'd like to try to improve upon for multiple stakeholders, for the children, for their parents, for the community health benefits as well. So our proposed solution is the Adaptive Sports and Inclusive Recreation Initiative. And I've just displayed a logo that is oval shaped with the letters ASIRI. And apologies, with yellow font. So our case for what ASIRI is that it's a program designed to increase awareness and knowledge of, access to, and participation in adaptive sports and inclusive recreation among students and physical education and their PE teachers. And we've found that this would be beneficial because embedding adaptive sports into PE curriculums or the curricula would satisfy the goal of each level of the socio-ecological model of health, which is a model proposed by the Centers for Disease Control and Prevention on how to basically have a healthy society. And it spans from the societal level at large to down to a community level and relational level and then individual level as well. So to move on to the methods, we'll give a quick overview of what the curriculum entailed. It was a 5-week curriculum that ran from August 2021 to June of 2022. And the curriculum consisted of 6 lessons with 4 activities that were taught over the course of the curriculum. And these included sitting volleyball, wheelchair basketball, wheelchair tennis, and adaptive yoga. And for the images that I just displayed in the top left, you have 7 children wearing red t-shirts sitting with their legs crossed on a wooden volleyball court as they pass around a yellow volleyball with a black stripe. The top right image for wheelchair basketball shows 6 boys sitting in wheelchairs in dark colored shirts looking up to the right as one of the boys shoots a brown basketball. The bottom left image shows wheelchair tennis with a boy with blonde hair and a maroon colored shirt sitting in a wheelchair holding a tennis racket as he tries to return the serve. And then the bottom left corner shows 2 women, one sitting in a wheelchair and one sitting on the floor, both doing an overhead stretch to their left. So each of the lessons kind of encapsulated in these images were designed to teach students about a different adaptive sport or inclusive activity in a progressive manner, while also introducing the fundamental principles of disability inclusion that met Michigan's PE standards in the state. There were 9 physical education teachers and 774 6th grade students through the public school district that partook in this program in its pilot year. And prior to each lesson that was taught by the instructors to the students, the teachers received or completed a disability awareness training and a training for each of the activities that you see on the screen. Meanwhile, the students were shown a 30-minute video designed to teach them about the disabilities and inclusive recreation activity before the curriculum began. In order to gauge the impact of the program, we conducted a series of surveys. For the teachers, this included 3 surveys, a pre-training survey, a post-training survey, and a post-program survey. While for the 6th grade students, we just had a pre-training survey and a post-training survey. And within each survey group, we had we used t-tests and chi-square tests for significance. So our primary findings were that students gained new knowledge about and appreciation for adaptive sports and inclusive recreation. Specifically, when asked in the survey, the students reported that they felt A-Series activities would not only be good for students with disabilities, but that they would also be good for all students in the school. And both of these survey results yielded statistically significant results. And the physical education teachers also reported of having a positive experience and satisfaction with the learning and teaching of the A-Series curriculum, although initially they were hesitant about the ability and their capability in doing so. I've just included here 2 photos that we had from that pilot year. The bottom left showing one of our team members, Christopher Kelly, helping a young lady on the left in a white t-shirt participate in wheelchair tennis. And on the right image is another example of seated volleyball with about 6 or 7 children playing as some of the faculty and our staff sit behind them or stand behind them to cheer them on. So in terms of conclusions, to reiterate, the goal of A-Series was to increase awareness and knowledge of access to and participation in adaptive sports and inclusive recreation among students and PE teachers. By the results and surveys that we've done, we were able to really clearly demonstrate that introduction into the K-12 curriculum was effective in achieving these goals. So for our future work, we really want to try to expand. I think there's a little delay on the slide, apologies. We want to expand the program and further analyze its impact in the different districts and different grade levels as well. And that expansion is actually ongoing currently, especially in this academic year. We've this will be entering its third year, I believe, and we'll be entering into 7th and 8th grade schools for 7th and 8th grade PE classes, and also hopefully into some of the public school district PE classes in Ypsilanti as well. So just to wrap up, I want to give thanks to the Michigan Health Endowment Fund for helping to give us funding for the equipment, putting this program on, the Ann Arbor Public School System for partnering with our team, University of Michigan Medical School for their support through faculty of Dr. Okunlami, and also for his mentorship was getting me involved in the program as well. University of Michigan's Adaptive Sports and Fitness Office, the U-M Project Healthy Schools, and the Center for Independent Living for all their support. Here are all of the references from my talk, and I guess I will table any questions that may come until our Q&A a bit later today. Thank you.
Wonderful. Thank you so much, Tommy. As you were right on time, I appreciate, if you're going to be here, the being willing to take the questions later. We did learn that Suhas will have to leave, so please put any questions for him either in the chat or the question and answer, and he'll answer them in that manner. Right now, we'd love to move on to Dr. Michael McKee as he talks about the Disability Accommodation Survey.
Thank you again. So this has been a great day to hear these different presenters, and certainly we'll be following up on what Dr. Powell is saying. And this is a quality improvement project that I will be outlining. Before we go further, I want to introduce myself. My name is Mike McKee. I'm an associate professor at the Department of Family Medicine, and I have a bilateral hearing loss. We're a co-current plan on my right side. For those who have limited, like low vision or blind, I am a middle-aged white male wearing a kind of a striped purple shirt and wear glasses in an office setting. So my title today is a questionnaire-based approach to assessing the patient disability and accommodations needs at a family medicine clinic. And so I want to acknowledge our multiple co-authors and collaborators. So Grayson Buning, Tyler James, Blair Richards, who participated in this project. We don't have anything to really announce or disclose, but do want to recognize the critical component, which was the Accessibility Task Force that really supported this work. And this is one of the many different projects that are part of the Center for Disability Health and Wellness. And we also want to recognize the funds that were provided through Michigan Medicine. So why is this topic important? I know I might be preaching to the choir here, but the key issue is that the healthcare inequities are substantial for people with disabilities. And I just kind of highlighted just a couple examples here. We have seen over the past couple years some really shocking articles that have come out, doctors reporting they don't want to have these patients in their practice. We have also, over the past 15 to 20 years, just had a series of articles highlighting these gaps in care, inaccessible services, programs. We heard certainly from Dr. Powell earlier today how that really just exacerbates a lot of the inequities that we experience. So just to kind of give a little bit of an overview, people with physical disabilities, accessible exam tables or scales. There was a study out in California. There's been other studies also in the Northeast, but bottom line is that primary care clinics rarely have these devices. And so 19.1 to 10.9% respectively had these available at the clinic. So that already excludes many of these clinics to be accessible for people with physical disabilities. Communication disabilities, you heard earlier also from Dr. Powell, where there's inconsistent provision of accommodations for people who may be deaf, hard of hearing, or have other communication disabilities. And one study, actually a few years back, looked at primary care providers with deaf individuals, and they found that only 17% of the primary care providers provided an interpreter in that setting. And so intellectual developmental disabilities, we see a whole bunch mistrust, misdiagnosis, polypharmacy, medication errors. And a lot of these have unfortunately driven inappropriate healthcare utilization, ED and hospital. So these are really huge challenges. And what we wanted to do is try to tackle these at a primary care level. So I put this quote here: you're only going to have a certain percentage of patients that are going to require accommodations, maybe 10%, maybe 15. So how much can you do? And this came from Dr. Legu's article last year in the Health Affairs. And this just really encapsulates what we often hear from primary care doctors, that, well, this is not a big population. 10 to 15, we know is 20 up to 26% by other data. That is not a trivial population. And these are people that unfortunately are being marginalized in our primary care settings. And so we are dealing with this sort of notion, like it's not really that important to address. And we need to just be very clear that healthcare inaccessibility and inequity is a form of social injustice. It really needs to be tackled. So our study objective, what we did is this quality improvement project. We wanted to really find ways to help us identify these individuals who have a disability, have what care needs and accommodations they may require. And this is really building on the disability accommodations tab, which we have part of our electronic health records. And I'll show a screenshot later on today. So the study assessed this is self-reported disability status, as well as accommodation needs among patients presenting at our one of our family medicine clinics. And this was only given for those in wellness visit. The reason for that, it was to make it more feasible, but it also models a lot of the questionnaires that are provided. For example, Partners in Care questionnaire, some of the mental health or behavioral health assessments, many of them are given at these wellness visits. So a little more time to finish these kind of questionnaires. We did this over 6 months last year. And again, the outcomes is prevalence of patients self-reported on a disability, as well as accommodations that may be needed. This was descriptive, given we had only one single clinic and a smaller sample. So we just revised our manuscript. So hopefully we will hear that this paper will be accepted. But in preparation for this, I just want to share some of our findings. So we disseminated and got 514 questionnaires back. And this was assessing the presence of a disability and if they need any accommodations. 13% of our sample reported having a disability. This is smaller than what we've seen in the national surveillance data. But most common was related to mental health and hearing related disabilities. 8% actually requested accommodations, and they were quite varied. And one interesting note to bring up is that not everybody was comfortable with disability, and that to me seems to be more with older adults who may actually describe it as a limitation, but they were still willing to list the accommodations that they require. So that might give us some future scenarios in which how we can kind of capture those people and not make them have to choose with a term that they may not identify with. And then the other thing that was really, I think, helpful for us to understand is that the accommodations, while varied, many of them were actually very practical, easily implemented. There's a notion among primary care doctors that if we start to inquire, it's going to be so costly, impossible to implement. And the vast majority of what was reported was not true. Many of these were based on assistive listening devices, inclusion of a support person at appointments, assistance with transfers, and even like transparent math, which are typically about $2 to $3. So our sample, given that it was in a more suburban, slightly rural area, skewed to be more middle age, more female, more white, non-Hispanic. Most of them were English speakers. We did have some that were sign language users. But again, just a reminder, 13% of the sample self-reported having a disability. So this is the table just highlighting the breakdowns of the disability types, in addition to what was the common accommodations that was requested. And this is, the percentages are based on the overall sample. So for blind, low vision, large print was actually the most common requested accommodation. And that was 8 individual. Cognitive, intellectual, or developmental disabilities was mostly around the inclusion of a support person to be part of help to facilitate communication, medical decision-making. 19 individuals responded in this area. Deaf, hard of hearing, or deaf-blind was the second most common disability type, and most of this was facilitating listening devices, American Sign Language interpreter, transparent mask. Mental health disability was actually our largest group, and they wanted modifications of care protocols, emotional sensory support. And then for mobility disability or wheelchair users was again transfer assistance and having accessible scales, equipment. Respiratory disability, while it's not a common one, is one that is not well captured in many of our screenings or identification with disability fields, but it's a population that we do need to pay attention. For example, masking, assistance with oxygen equipment, tubes, nasal cannula. And then speech communication disability, again, it was more about making sure that the communication was effective, provider have an opportunity to confirm understanding. That could be like a teach back approach. And then other sensory disability, that was mostly around environmental modifications, fragrance-free environments, so it doesn't trigger migraine, for example. Upper body, fine motor skill, 8 people responded in this category, and they mainly needed assistance with completing patient forms, and also if they needed to be disrobed. So this is the first known study in a primary care setting that looks at the disability type as well as accommodations at a primary care clinic. Obviously, limitations is a single clinic, so more needs to be done to get more representation. It's also self-reported. Disability is common. We all know that is unfortunately overlooked, and screening can help providers and staff become aware of the backgrounds, the characteristics of our patients, including disability, and find out ways we can improve the care. And that's going to require making the visit accessible and effective. And then again, just a reminder about accessibility is legally mandated. We have a long way to go to make sure that that it is actually in effect. And then better patient satisfaction and outcomes are really what we're looking for. So this is just a brief screenshot of the disability accommodations tab. This is part of our My Chart, and the questionnaire is just another way to capture this information, and we upload it into the patient's files so that they're permanently stored and not just one time and lost. So again, the patient with the disability is generally the expert on what they need. We heard that loud and clear with Dr. Powell. So I'm going to stop here. Here's my contact information. Thank you for letting me join today.
Thank you so much, Dr. McKee, for this important presentation. I'm sure you'll have a lot of questions either in the chat, the Q&A section, or at the end of the day. And I'm delighted to introduce our next presenter, Rahaf Al-Harabi. If I pronounce that correctly, not, they can correct me, will now be presenting our next exciting presentation related to accessibility and disability.
Yeah, thank you so much. You pronounced it perfectly. Yes, I'm super excited to be here. I am a PhD candidate at the School of Information here at the University of Michigan. And to give a non-visual description, I am an Arab woman. Super excited to present my research on accessible and privacy-aware technologies with blind people. Okay, so to give a little bit background of my work, I wanted to introduce the idea of visual assistant technologies. So at a basic level, these are mobile applications that are currently available in Apple or the iTunes store, and anyone can download it. They are designed for blind people to enable them to access visual information. So for example, if a blind person wanted to know the expiration date of their milk, they can pull up these applications and ask that question and get visual information. And typically there's two types of applications, and they're divided or classified by the medium of description. So the first type is artificial intelligence enabled, meaning that AI would analyze the visual content and then provide description. And the other type is human enabled. So the process of description is mediated by sighted volunteers or trained agents. And beyond the milk example that I've just shared, blind people use these applications in their everyday lives to conduct a variety of tasks like reading printed and handwritten text, picking a fashionable outfit, or navigating an unfamiliar space. So despite their many benefits, these applications have privacy implications. They include unintentional privacy disclosure, meaning a blind person may unintentionally include something in the background, and that might be noticed by a sighted volunteer or stored in the databases of AI applications. There's also intentional privacy disclosures. A blind person may knowingly use these applications to access private or sensitive materials because they may not have other ways to securely do so. These privacy leaks can lead to risks like identity theft. And one of the big questions in my field is around how can we build technologies that prevent and minimize these harms. And researchers have been building and designing an AI system called obfuscation to address these privacy issues. So let's go through a scenario of what obfuscation might look like. If a blind person wanted to know the expiration date of this milk carton in this less than ideal environment, this is a very messy kitchen where on the left, there's a pile of unwashed dishes, and on the right, there are leftover food. Some blind people might feel very uncomfortable using a visual assistant technology in this context. For sighted people, they could potentially manipulate the camera view to only show regions of interest, but that might be difficult for blind and low vision people. So the idea behind obfuscation AI is to train systems that detect private or sensitive elements, and then hiding them by blurring or placing a black box, so that in this case, theoretically, a blind person may feel more comfortable to use visual assistance technologies. So I wanted to study this so-called state-of-art technology in the AI field, and I wanted to do that by asking and posing this following question. How do blind and low vision people want to experience and engage with obfuscation? And to answer this question, I took an in-depth qualitative research approach. I collaborated with the National Federation for the Blind to recruit participants, and we interviewed 20 participants who are blind and low vision and regularly use these types of applications. Because talking about obfuscation is largely inaccessible to non-technical participants, we were inspired by speculative design approaches to include an imagination session where we accessibly described obfuscation and asked questions around how participants imagined obfuscation and how would they improve it. We used reflexive thematic analysis to analyze our transcripts. Now I'm going to share some key findings from our research. Our participants shared with us the potential benefits and harms of obfuscation. And just as a heads up, throughout this talk, I'll be using pseudonyms to refer to participants. So participants often use these applications to access sensitive information like medical documents, and they imagine obfuscation could preserve privacy. For example, Danielle was recently discharged from a hospital, and she was given a pile of paperwork that included her name, procedures, and medications prescribed. She hoped obfuscation could remove sensitive details like her name, while still enabling her to understand care instructions. In terms of harms, participants worried that obfuscation will not account for their diverse and complex privacy decisions, and that they won't be able to accessibly confirm obfuscation results. Blind people are not a homogeneous community. Their privacy decision is impacted by a number of factors, including racial and ethnic identities. Blind people also make complicated decisions around privacy. Gabriella presented us with a thought-provoking example. She asked, and I quote, "So let's say it's a picture of a naked child. And I'm using this example because when you think of a naked child, our automatic response is no, absolutely not. But what if there's a concern about a child getting hurt?" Gabriella underscores that privacy negotiations are contextual, and what might be sensitive and personal for one person could be a matter of identification and reassurance for a blind person. So it is important that when we're designing and building AI systems like obfuscation, we need to recognize the unique and complicated nature of privacy decisions, rather than assuming that a universal set of content should always be obfuscated. Lastly, given their experience and expertise with AI, blind people know that AI is not perfect. They know that in order to receive a close to accurate response from AI, they need to be in a well-lit area and they need to position their camera perfectly. So this is why the second major finding was around making sure that obfuscation worked correctly and as expected. Participants pointed out that it would be very difficult to non-visually confirm obfuscation. Ruth said, and I quote, "Blind people may think it's blurred, but maybe it isn't actually blurred, and they don't know it because they can't see it." Without a way for blind and low vision people to non-visually interpret outcomes, obfuscation systems might be inaccurate or shift around as users move their camera. Taking a step back, what do these findings teach us about obfuscation more broadly and conducting research with blind and disabled people? So when I present this talk to a technical audience, I tend to focus on how can we design better systems. But in this presentation, I wanted to leave you with takeaways that are potentially relevant with your research and collaboration with disabled people. And having listened to the majority of presentations here, I really want to say that I'm probably pitching to the choir, but I'm glad to be a part of this community. So our findings teaches us two things. That first, we need to move beyond a singular identity approach. And second, we need to recognize the added effort on disabled people. So again, blind and low vision people are diverse, depending on factors such as race, gender, sexuality, and even parental or caregiving status. Blind people have varying concerns and needs. In my work, I call on researchers to understand privacy beyond a singular identity approach and towards considering intersectional privacy needs. I think that this commitment can be practiced for all types of research with disabled communities, enabling us to uncover rich and nuanced experiences. Our findings also emphasize that blind people are not passive recipients of help, but they are actively involved in the process of accessibility through making sure that they're positioning their camera correctly and confirming that they're in a well-lit environment for AI to work. Adding AI features like obfuscation doesn't necessarily decrease burden through automation, but it could lead to additional harms and added cognitive load. So how does this point extend beyond my research scope? Whether you know it or not, we all work with disabled people every single day. The labor of accessibility should not fall solely on disabled people, but everyone has a role in co-creating accessible spaces. For example, physicians can take the extra time to make sure patients have access to instructions that are accessible. Accessibility is a community-driven process, and we all have a responsibility to make our workplaces and environments accessible. Finally, thank you everyone for listening. I wanted to acknowledge my collaborators, Dr. Robyn Brewer and Dr. Sarita Schoenebeck, as well as our sponsors. I've included a link to my paper and happy to take questions today or online.
Wonderful. Thank you so much. This is such an exciting progress, and we look forward to your continued involvement in both CDHW and the conversation later on. And our final paper today is the impact of vision impairment in the workplace by Erin Klukas.
Hi, good afternoon, everyone. I'm just going to share my screen. Dr. Erin Klukas, I am an optometrist at the Kellogg Eye Center, and today I'd like to share some research titled The Impact of Vision Impairment in the Workplace. This research has also been done by my colleagues, Dr. Donna Wicker and Dr. Sherry Day, also optometrists, and our occupational therapist, Ashley Housen, that we work very closely with. So we know that obviously that vision impairment creates challenges for employees in the workplace. And even though there has been several articles to discuss accessibility and advice to employers or protections for workers through the ADA, there's been insufficient direct feedback from working adults with vision impairment. So to explore this, we set up a survey that was provided to employed adult patients in our low vision rehabilitation clinic at the University of Michigan Kellogg Eye Center. This survey was followed after the patient's appointment with an optometrist that identifies what optical devices may help the patient, and also with our occupational therapist who discusses more about adaptations in the home, electronics, as well as services in the community that can help folks with vision impairment and provide resources that way. For our inclusion criteria, we had patients with a Snellen acuity of 20/60 or worse, and those with near normal Snellen acuity of 20/50 or better were excluded from the study. Our survey demographics showed an average age of almost 48 years old and over 63% female and 37% male. Our average best corrected acuity, or the best that a patient could see with their current glasses or contacts, was around the 2100 range, which meets legal blindness requirements. Average contrast sensitivity, or the ability to see different shades of gray, was reduced. And 5 of the patients out of our 30 had severe visual field loss as well. We asked about employment status. 80% were full-time employees and 20% were part-time, and 13 were self-employed. 43% had graduated college, while we also had a population that had some college experience of 27%. And average full-time salary was around $71,000, while the average part-time salary was a little over $12,000. This is, I think, the most interesting slide that we have here, our results in response to questions about discrimination in the workplace due to visual impairment. So 87% of the patients that we surveyed said that their vision had worsened during their working years, and 22% said that their employer did not know of their visual impairment. A really kind of unfortunate percentage of 70% of patients said that they reported discrimination at their workplace due to their visual impairment. 87% reported that their vision loss impacted their work performance. and 20% noted a moderate or significant impact on their ability to achieve work promotions. On the right side of my slide, I have a little table that shows free text responses from patients answering the questions: in which way have you faced discrimination at work due to your visual impairment? I'll read a few of them out here. We have one patient stating that training, I feel overlooked and passed over because of my vision. Another one stated that she felt like her vision had resulted in her getting paid less. Another patient stated that I have to fight for everything, especially accommodations. And another patient stated that her boss felt bad for her and won't give the same opportunities because they're worried they can't do it. We also asked about how patients are creating their own adaptations at work, how they're able to still work and be successful. 83% had used computer adaptations with enlarging software and large computer monitors. And 70% relied on low vision devices such as magnifying glasses, handheld or stand magnifiers, telescopes, or electronic magnification devices. Only 8 out of the 30 participants had received adaptation devices from the Michigan Bureau of Services for Blind Persons, or Michigan Rehab Services. Only about a quarter had received assistance from their workplace, and over half had to purchase these low vision devices for themselves. All right, on this slide, I do have a picture of a large screen computer monitor next to a standard size. This helps to make print larger for patients to be able to read. And just kind of shows, you know, kind of a simpler way to achieve goals with vision impairment. Of course, not all patients would be able to magnify to be able to read computer screens, where other devices such as text-to-speech would be more suitable. So all this feedback from employees with vision impairment illustrates their perspectives on discrimination and their barriers to success in the workplace. Even though the ADA directs employers to provide reasonable accommodations, our studies show that most employees with visual impairment still experience discriminations and obstacles to work advancement. And we also identified that the purchasing of low vision equipment frequently falls on the workers themselves, even though computer adaptations and low vision devices are considered vital tools in career success. And definitely feedback from the visually impaired is needed to optimize success in workplace. Also on this slide, I have a photo courtesy of a patient used with their permission of a workplace. This patient is a music teacher. And on the left-hand side, we have a student's piano where a student would sit and play the piano. And on the right, we have an electronic keyboard that on top of it has an iPad with music. And that iPad is connected to a large TV screen, which is above it. So this electronic magnification setup allows the teacher to read the music as the student is playing along. So in the future, we definitely need a further analysis on the specific barriers to folks with vision impairment in the workplace, and also ideas from patients on how to improve our role in prescribing devices for specialized working tasks and for their employers' understanding. And these are my references. Thank you.
Thank you very much, Dr. Klukas, for a very exciting presentation. With that, I would like to open up either the Q&A or the chat. Please just raise your hand if you have a question or comment for one of our panelists, especially those from the afternoon who may still be around. So here, waiting for questions are Dr. Klukas, Lahab Al-Harbi, Dr. McKee, Mr. Lowell, and all are able to answer questions about their exciting program. So I'm gonna just check my chat quick. Are the questions and answers? I think I'd like to throw a general question out to everyone, if that's okay. Given your knowledge now and your interactions with policy, what would be the one policy issue you would focus on? What would your one pager be about, and who would it be directed to?
I can share a little bit.
Please.
So my project is what we call like a techno-solutionist approach, meaning I've centered how technology can address this issue. But as I've shown in my slide, it's really more complicated, and that this technology approach to solving privacy needs adds additional barriers. So I think the next step is to really think about policy in the sense of how can we regulate these applications to take the privacy considerations of blind people more seriously. So currently a lot of disability related technologies hides under the guise that they are for the social good and that they are enabling people with disabilities to be independent. And I'm not saying that they don't have any benefits, they do, but I don't think that this discourse should erase their potential harms, especially in regards to privacy. So if I were to write a one pager, it would be around regulating to what extent do these applications collect data and provide meaningful ways for blind people and people with disabilities to opt out from these ubiquitous data collection regimes.
A very important issue. Thank you very much. Tomi?
Yeah, can you guys hear me all right?
Mm-hmm.
Okay. I think, let me put my hand down, I guess. With respect to the Adaptive Sports and Inclusive Recreation Initiative, I feel like it's something that should just be in every school. Like, I wish I was offered the ability to play these sports, like when I was in 6th grade. And something I forgot to mention actually is the reason 6th grade was chosen is that according to the CDC, that is the age at which, or the grade at which, most children are increasing in their autonomy. So they're able to engage with more things like after school activities and sports. If you reflect on your own childhood, like you might see that to be true for yourself. So as such, it's a time when you're able to learn new values and kind of start incorporating levels of independence and things and just normalizing things. So like, I would think it's imperative to just get that as standardized as possible. It'd be lovely if we could just like have that be, handed down through Congress in some manner, but given how, unique each state is, I guess what would be more impactful likely as a one-page policy note is to just give that curriculum template to each state government and allow them to show, with Michigan as a model, how we've been able to make that work within our state's physical education standards, and allow them and encourage them to utilize that for themselves as well.
Right. Thank you. Dr. McKee?
For me, I think a key area is moving away from just the blame game, which we all recognize that there are some, significant healthcare inequities, but we need to move away from just focusing on that to finding a way that actually could be more collaborative, supportive. I use this project for primary care, but primary care providers are also overwhelmed. And so it is critical for us to make sure that we think about the whole picture. Some of this is also a business approach in terms of better reimbursement. There are some models that are being proposed to help to make this more feasible. And the other thing is that relying on doctors when this is a healthcare team is going to backfire. A lot of these accommodations are going to need to be set proactively and are going to require other staff or maybe even new people to actually implement these changes. So there's a lot in that one pager, but I would just emphasize on new models of care that is actually supports and hopefully makes this whole process a bit smoother for both parties, healthcare side, as well as patients with disabilities. And there's a few options.
Wonderful. And Dr. Klukas?
So with a lot of patients not being able to receive low vision devices through their insurance or even state services, there's definitely, a significant out-of-pocket cost for patients, which many can't afford, and which then kind of snowballs into not being able to work and just turning into a lot of not good stuff. So I would, kind of, if possible, encourage, at least the Michigan Bureau of Services for Blind people to really kind of, either develop a program to help those who are still working. And with the Michigan Services of Blind Persons, that's also for legally blind folks. So with 2100 vision or worse, which still, people can have low vision and still struggle with work in that response too. So maybe a more achievable goal would be to discuss with patients about, is their workplace accommodating them? Can we write letters, from providers to these workplaces to make sure that they comply with ADA, and kind of move forward together that way, since, state services and expanding Medicare and all that's, would be wonderful, but maybe not achievable.
I think these are all wonderful ideas, and it's important to think specifically what the problem is, and then probably the range of target audiences for the ask, because there's not just one approach. There's a lot of people involved in these solutions. There's the big picture policy, and then there really seems to be some of these refined processes that have to be informed. It's not just, as you said, Dr. McKee, that physicians should do that. There are a whole set of environmental factors that impact the ability of physicians or healthcare providers to provide services, including, do they have time? Will they be reimbursed? Are those accessible accommodations, readily available? And who then makes those decisions? Who are associated with it? And the same way, Dr. Mr. Lawal, that it is a matter of the state, but on a more practical matter, it may come down to the physical education teachers. Do they have this information? Do they know what's available? Are they getting this in their training? Is this part of their best practices and clinical guidelines? And so, I think sometimes thinking about who's willing to partner as the low-hanging fruit, who's excited about this, and then the surrounding a problem by the multiple solutions or multiple ways that we can begin to chip away and really try and enhance equity when it comes to health and healthcare and other outcomes for individuals with disabilities. We still have, I'm wondering if we have other questions or comments by attendees. We've heard so much today, and it's so exciting to think about how all these fit together. And it was really amazing to me, at least, the connections that all of these presentations have with policies and how well they flow into one another. The key pieces being the partnerships with people with disabilities, with disability communities, knowing that, you can't have solutions without their involvement. And then recognizing the intersectionality, as you said, Rahaf, that there isn't one identity. There's not, we have to look at people's different concerns and needs and have that at the table. There's so much that we've talked about today. And so I would welcome other people to reflect on that or to ask questions.
I think one of the key things is that we heard lots of different really creative approaches, also in-depth findings on where there's still gaps. But I still feel that there's still opportunities to collaborate. For example, we heard, AI obfuscation, that AI is sort of another area that's both a threat and also a possible opportunity. Dr. DJ or Dr. Jane at Computer Science is also doing AI for deaf and hard of hearing individuals. And so it would be really helpful to kind of think about tech areas in which exchange ideas and to hopefully not replicate mistakes, just to be mindful of where there may be pitfalls and creative strategies around that. And so I think this is hopefully maybe a start to find ways where we can be better informed about what everybody's doing. And I know that's a challenge here, even at University of Michigan being a large place. But that would be one I would hope that could be a next step for all of us.
This is all wonderful information and just really enlightening. And I'm so glad I was here for the second part of it. I just wanted to offer, if any one of you would like to connect with organizations of people who are blind or low vision, visually impaired, or also, I don't know, Tommy, if you know, over at DMC, Mario Dixon, and any of the, any of the wheelchair basketball team players. I could also connect you with them over at Rehab Institute of Michigan. They have a great program over there so that you all can get some firsthand information from people who are passionate about their lived experiences. And also, Dr. McKee, if you have that information, you talked about doctors who don't want to have patients with disabilities. Did I hear that correctly? I'd be interested in that because I personally have had some experiences in doctor's offices that really surprised me. And when the attorney earlier mentioned attitudinal barriers, oh my God, that just really, blew me away. Because a lot of times when you go into offices and you interact with people and you feel as though, as a person with a disability, that maybe you've been treated differently, you feel like, is it me or is it them? So actually to hear that is something that other people are have experienced is just really an eye-opener to me, because I'm working with a system right now where my care is being put off because of people not understanding how to communicate with a person with a disability. So this is all really, really, really something that makes you feel a little more confident, maybe makes you feel a little more at ease in getting out and being understood. So thank you. Thank you.
Thank you, Lisa. It sounds like what you heard really validated your experience and said, okay, this is a real thing. And I think what you also heard are a wealth of people who are recognizing this and trying to take it on. Well, I know one of the new, you may not have heard, or I'm not sure if you picked it up during Dr. Powell's presentation, but NIH, which is one of the key funders of health research here in the United States, recognized individuals with disabilities as a marginalized and priority population, which should hopefully really bring more awareness and conversations to this topic. And in particular, they have a call out now for, identifying and addressing ableism within healthcare settings on both the individual level, the attitudinal level, as well as the systemic level. And, there really is, I believe, more and more people recognizing, joining together, talking, trying to push for change, and more opportunities to have voices heard. But that said, I think we do have to take it. We have to figure out how to work together, because often I know disability advocates are burnt out. You've been working hard for a long time, and especially during COVID, making sure voices are heard, concerns are addressed, and that the proper resources are in place. And so now that there are opportunities, how do we make sure we take advantage and provide that input, whether it's to the Rehabilitation Act, any of these other initiatives that's coming forward. Right. Okay. There's a question for Michael from Leslie. Leslie, did you want to say this, or Michael, you want to read it? Oh, there we go.
Yeah, I'll unmute. Michael, what was the age group of the individuals that had that issue with the doctors or the doctor's offices not, didn't want them as patients? Because I'm just curious, because my work has been with 16 to 24-year-olds, and I struggle with that group for consistency when it comes to transferring those medical records over and then moving into adult spaces where now you have to reestablish care. And sometimes those medical records just don't transfer over quickly. And I'm not fine. Well, it's so difficult to follow the data, when you're working with that population. So it becomes a challenge as they transition. And if they move like out of state, all states are different. So it becomes even more precarious, as far as medical records go.
Thank you for that question. So this particular article, we have it posted on, I don't see it on the Q&A, but I put it in the chat. Hopefully we can verify that for both Lisa and possibly for Leslie. So Dr. Legoo, these were a series of interviews with a variety of physicians, and it was really talking about patients with disabilities. It was not specific to like a pediatric or even young adults. But with that being said, transition, like transitional care, going from adolescents to adults is a grave issue, and a lot of people struggle with that. And that's especially true for primary care doctors when you get into the adult age. There's not as much that I recall from my review in terms of pediatric age where doctors have commented that they do not feel like they want to work with them. It may be more around lack of training, some of the challenges. Again, some of them are just managing complex care. Some of it is care guidelines that are more for the general population, but not very tailored for that individual. So it's not really specific to the age that it sounds like you're really targeting, but I think it's still very relevant though.
I do a lot of work with those young people aging out of systems, and now, you have to put them in either further education or training, and then they go to work and everything. And it's very difficult when you talk about functional assessment and having that medical record, because in some instances you have to reestablish all of that because they're going through that redetermination process with SSA. And then it's important because that determines whether they're able to go to work or how they're able to go to work, as young adults. So it all works together. Like Michelle alluded to, it all works together. All of these conversations are very necessary. And we have a lot of work to do with regard to individuals, that experience a disability. It's a lot of work.
I will add one other additional comment, given that we're talking about young adults with different types of disabilities. So the disability accommodation tab was really sort of the idea behind it was spearheaded by a patient that the interpreter services, myself, many of us were taking care of. And this individual struggled with feeling like having to repeat, these are my care that I need. These are the accommodations I need. This was an individual with different types of disabilities, some dual disability, and just feeling frustrated, even here at Michigan Medicine. And so the importance of why can't you guys all understand once and for all, these are the things instead of having to repeat over and over again. So that was a powerful, it was a powerful impact and really kind of prompted, it got us moving forward on this idea. So even one person can create a lot of change.
It just goes back to, I think, Rahaf, the data collection and AI and all of these things that are coming. We haven't done well yet on how we manage that data, how we utilize an individual's data in that regard. And it is coming, AI is coming. So we have to consider all of these pieces on how we're going to address that, especially if we need that data to help people design systems and test systems in a real way. Because we know we're not included in some of this research that they're doing. So how can you create systems that partially include us or don't even include us at all? So it's a challenge. I just think about it. My work at NIH is we have a partnership with SSA. And so we're trying to really push them to look at that functional assessment, the medical record. We do a lot of work with natural language processing, deep learning, and all of those things. And I can tell you the AI and the data, the use of data is a big issue.
Yeah, I agree. I think you raise a really interesting point because there is a trade-off. We do need data from disabled people in order for these systems to actually work. So there's the idea of like disability deserts where we don't have enough data about people with disabilities to actually build these systems in a way that is inclusive for them. But I also think that we can do this in a meaningful way that centers consent in a way that we are ethically sourcing that data. So I agree that these systems should be inclusive, but I think we have to do it in a meaningful and appropriate and a way that allows people to opt in or opt out rather than just collect this data without them knowing and without their consent.
And
Absolutely.
I would love to jump in there because it really occurs to me that this is where your expert knowledge is really going to be critical when it comes to policy. Being able to provide some of that nuanced understanding about how bills are written or how these processes are developed and issues of privacy and confidentiality of data, because the lobbyists are going to say, just give it to us so we can sell it. Just, who's going to be the loudest voices or wants that data, and having a recognition of the unique concerns. Well, the civil rights of everyone, but the unique concerns with this type of data, I think is going to be critical.
Yeah.
So thank you. Karen, would you like to jump on and make your comment?
Oh, sure. And I've been listening with great interest to all the commenters and the comments. The presentations were awesome. I've learned a lot, and thank you all for your participation. I thought about a lot of things as the discourse was ongoing. And as a former rehabilitation counselor who worked in the state of Georgia, I spent a lot of time primarily working with the deaf, hard of hearing, low vision, and deaf blind population. I find here in Michigan, as I've tried to seek employment as a rehabilitation counselor, I had some difficulty finding a suitable place to work because there aren't many opportunities for rehab counselors, or RCDs as we're called, to work in the state of Michigan as a counselor who specializes in working with the deaf et al. Population. I started my own business because I wanted to do more proactive work outside of the state entity, and finding even there that there's still so many unmet needs that are presented here in the lower portion of the state. The availability of certified and qualified interpreters is sorely lacking, primarily due to the new laws that have been enacted. You know, we could just interpret previously without any certification, but now we have to pass tests, you know, and take the BEI and you know, get our NICs and things like that. So I kind of shifted into another area of service provision where I am currently working with individuals who have had had loss of limbs. I know I just took a whole nother swing, another turn into another whole nother area. But since I have received, have had an amputation, I've been an amputee for about 8 years now. And so I shifted my focus because I see now that as I return to Michigan, that the barriers that are presented in housing are quite prevalent. And a lot of houses are not equipped to handle persons who are, I mean, just in general, who have some types of wheelchairs or need to use wheelchairs or have some mobility issues. That's what I'm actually saying.
Right.
So I've kind of shifted my focus on working with the Fair Housing Act and trying to find ways to provide better and more suitable housing accommodations for persons with disabilities. So when I first returned to Michigan, I had some trouble, difficulty actually mounting steps, you know, and going up some built into some buildings because a lot of them are quite older buildings, and they aren't very accommodating in terms of the number of steps and, you know, things like that. So so currently I'm working on advocacy and working with some of the I would like to work with more of the individuals who could provide something in terms of assisting individuals to get into suitable housing.
And you're talking in the right place, at least some of it. If you look in the chat, you'll see that Lisa Franklin just put her contact information there. Whereas on Wheels of Metropolitan Detroit has been advocating for accessible and affordable housing for quite some time, where there are also partnerships that CDHW has with Communities First, which is working with low cost and affordable housing. And once again, is emphasis on increasing awareness of issues of disability and how to provide wraparound services and supports for the groups and populations. So
definitely touch with her.
Right. There's a lot of work to be done.
There
and
is.
It's how do we work with people who are already aware of or also interested in these issues, and whether this is about employment, whether this is about health and fitness and recreation, whether this is about technology. You know, we can all inform each other in terms of the processes and approach. We all want to move the needle. We all want to impact systems. And so this combination of research, clinical care, program development, advocacy, it keeps supporting policy change. I think it's for that reason we're so excited that you each came today, that you were willing to present. And we thank you, and we hope that you keep connecting with the Center for Disability Health and Wellness. Fill out the surveys, give us your ideas. You know, currently the presentations we only accepted those with a connection to the University of Michigan. Should we make this larger? Should we make this a national conference? Who should we connect with? What type of conversations? Should there be a specific focus, maybe on assistive tech, on AT or approaches to be enhanced healthcare access? We just want to, there's a lot of work going on. We want to keep promoting the best. We want to keep learning from each other, and we want to keep using those levers to influence change policies and outcomes. Dr. McKee, any final thoughts?
No, I mean, again, it's been a great day to hear all of us come together. There's certainly a lot of challenges out there. And this is really why working together to step by step, hopefully address some of these inequities, break down some of these barriers. But I am always excited to join these kind of symposiums because I see the breadth of different projects that are being done, the different skill sets, the different people who are really just plowing ahead and paving ways, creative ways to address a lot of these gaps. So thank you so much.
Thank you. Have a great evening and a great weekend. Bye.